Yes, perfect. Good morning to all of you, and good day to the audience that is following us online. My name is Haris Lizidakis, and I am the Chief Executive Officer of WONCA, the World Organization of Family Doctors. Welcome to Brussels, and welcome to this final event of the MDD Minds project, where we gather together to celebrate the achievement of this great project that was led by our Working Party on Mental Health. Major depression is the leading cause of disability worldwide. And family doctors are those who diagnose often and offer support at the first level. However, there are primary care professionals and family doctors lack resources, lack support to properly care for our people with major depression disorder. And this is exactly how the MDD Minds project was born, because we would like to equip and our family doctors and primary care professionals with the tools, the knowledge, the network to support and improve care on major depression disorder. So without further ado, welcome to this day. We will hear many stories about this project, success stories, but I think the most important thing is that we will celebrate the community of WONCA as well, coming together to bring about such an important project. Thank you very much, and we will start first with an introduction, a welcoming video from our president, Professor Karen Flegg. Thank you.
Dear colleagues and friends of the MDD Minds project, my name is Associate Professor Karen Flegg, and I am the President of WONCA. Depression is the most common cause of disability worldwide. Rates of detection and treatment of depression remain low, especially in low and middle income countries. Today, we gather to celebrate the success of the MDD Minds initiative. This project has significantly enhanced the quality of care for patients with major depressive disorder. MDD Minds involved almost 3,000 family doctors and practice teams across 9 countries in Africa, Asia, and Ibero-America. The success of the project is a testament to the hard work, dedication, and collaboration of everyone involved. I wish to particularly acknowledge the work and dedication of the steering committee of the project. In particular, Doctors Chris Dowrick, Christos Leonis, Haris Lizidakis, our CEO, and Roberto Munoz Sierra, together with Mosaica Solutions, our project partner. We know that family doctors are in a unique position to offer effective, evidence-based care for people who experience depression. The MDD Minds initiative has strengthened the capacity and capability of family doctors and primary care teams to diagnose, treat, and manage depression. This is so important for what many of us believe is one of the commonest problems in our family medicine clinics. MDD Minds also highlighted the critical need for healthcare provider self-care. WONCA, via our Working Party on Mental Health, has a long-standing commitment to the integration of mental health care into primary care. I congratulate the MDD Minds team on meeting all objectives set out in the proposal, including diagnosing depression in culturally diverse settings, selecting appropriate treatments, managing comorbidities, and developing team-based care. As we celebrate the MDD Minds achievements, let us also look ahead to the future. The MDD Minds model provides a framework that can continue to be used for sustainable impact in mental health care. In closing, I want to reiterate my congratulations and on behalf of WONCA, express my deepest gratitude to everyone who has been a part of this incredible journey. There will be many family doctors and even more patients who will benefit. Your hard work and dedication have made this project a success, and I'm incredibly proud of what has been accomplished in just over 2 years. Thank you and congratulations.
Thanks to Professor Karen Flegg for the great introductory video. It is also my pleasure to introduce now to Dr. Steve Moll, who will bring, who is the honorary committee.
Thank you very much, Harris. It's a great pleasure to be with you all today. When I had the opportunity to come and share this celebration with you all today, I said, yes, I definitely want to come. And the reason that I really wanted to come is, for me, mental health is such a core to who I am as a family doctor, but particularly in the practice where I've worked for the last 25 years, we actually have the second highest prevalence of mental illness in London. So it really is something that's just so important. It's so integral to who I am as a family doctor. And I think so often other physical illness gets the priority. And, you know, this is something about equity, that actually we've put a shined a light on mental illness. I also came today because I wanted to particularly thank our visionary CEO, whose idea behind this project came from Harris, and Harris has really worked incredibly hard to make this a reality. And he does these things very modestly in the background, and things just happen. And things like this don't just happen. They come together because enthusiasts like yourself come together. You know, I'm very grateful to the Working Party, our professors, Christos Leonis and Chris Dowick. I'm so sad Chris is not here today. I know Christos and Chris have a very long collaboration for decades, but actually you've brought that great experience to everyone, and it's just so wonderful to see the spirit in the room here. It's very powerful. There's a bit of magic that's gone on through this project, I think. And of course, you are pioneers. You are pioneers for WONCA. This is our first big project like this. And you have really set the blueprint of how we can work together globally. And that's so exciting for me as a member of the WONCA board to see this actually come to fruition. And you know that you've done more than just this project. The fruits of this project will go on in other projects. We will learn from how this has worked, and we can do it again and again. And this is really going to help develop WONCA massively as a global organization for good. So a huge thank you for that. And finally, I'd like to thank Roberto and the rest of the Secretariat, because they make these things happen. They make it look easy. We've got Dermot here on the tech, and everything just works and happens. And actually, that's all through their great expertise, but their commitment to making our organization work really well. So I'm really grateful to you, to Harris and the whole team, and I'm looking forward to hearing more as the day goes on. So thank you so much for having me, and I look forward to hearing more about the project. Thank you.
Thank you, Steve. Now, and thank you for your very kind words, it's my honor to introduce Professor Chris Dowrick, who unfortunately is not able to be together with us. However, Chris has been the driving force, the father of this project. Yasmin is making hearts, and I think that's a proper gesture of recognition, because he has been the leader behind the project. He believed in that, and he walked us through it for the past 3 to 4 years, and we're here because of him. So we will now play a message from him where he is introducing the MDD Minds to all of you. Thank you.
Hello, I'm Chris Dowrick. I'm getting in touch with you from Liverpool in England. I had really hoped I was going to be with you in Brussels. But as you've probably gathered, I've not been very well recently, so I was advised best not to travel. You're going to have a fabulous meeting. This MDD Minds project is such an exciting one. So I'm delighted to have been part of it. I'm delighted to have an opportunity to share a little bit of what I've been involved with and some of the headlines now before the full meeting gets started in a few minutes. So I'm just going to share my screen, keep talking, and talk you through some of the headlines, as I say, what MDD Minds for Primary Care has been about. So if I can get this to work. On to my next one. Yeah, so just a bit of context. Let's move myself out the way a minute. So as I'm sure you know, depression is one of the, if not the leading cause of disability across the world. And there's nevertheless a big treatment gap between those who need help and those who get it. And that's particularly prominent in low and middle income countries. On the other hand, WONCA as an organization has been committed for decades now to the integration of mental health and primary care across various sectors. And as we all know, family doctors and their teams are particularly well placed to help people who are experiencing depression and similar. The background to MDD Minds. Several of you, I think, have been involved in the last few years in pilots on mental health, on advocacy, and on Train the Trainer. The advocacy is worldwide. Train the Trainer was in mostly in Asia. And then Mosaic, our partner group with Mary and Shelley in the lead, did a really important mental health needs assessment across Latin America with colleagues in WONCA a couple of years ago. And then as a result of those things, we've been working together, the Working Party for Mental Health and Mosaic have prepared an application to Pfizer to scale up some of these ideas, which is where MDD Mind comes from. It was an unrestricted grant from Pfizer. There's no pressure to have any particular activities or outcomes. So MDD Minds, we've been taking part in 9 countries across three regions, South and Central America, Africa and the Middle East, and then Asia Pacific. You're going to hear a lot. I'm just giving you headlines. You're going to hear a lot more about all the details. And I know many of you in the room have been actively involved in these places. The structure of the project, broadly 5 structures. I'm just going to spend a minute or so on each one to tell you the headlines of where we are, where we're up to, what's been happening. But it's all about capacity building in primary care to help people manage and care for those with serious depressive disorders. So curriculum development, that was the beginning, guided by the WONCA Working Party on mental health. You'll recognize many of you, your own faces in that assemblage from a video call a few years ago. Going round clockwise, the international collaboration was developed by a master faculty of mental health experts from 12 countries across Latin America, Europe, Africa, the Middle East, and Asia. And then we spent a lot of time adapting the curriculum to the specific needs and cultures of each region, with a focus on relevance and applicability. Okay, so phase 2, which was at the first bit of course delivery, we called MDD Minds 101. That was the foundation for the whole thing. It was a self-paced online course involving 7 modules in which we introduced key mental health care concepts. Multilingual access available in English, Spanish, Portuguese, and Japanese. We used an advanced user-friendly online learning environment, and the aim was to engage with about 750 participants from the 9 countries that we'd identified. Just a couple of examples here. This was an example from one of the early modules on introduction and the burden of depression. We're introducing a screening questionnaire called the PHQ-9. This is a fictional patient filling it in, but importantly pointing out that you can't rely on depression screening questionnaires. You have to use your own clinical judgment as well in deciding what the problems are and what to do about them. And this is a Portuguese version from the module on pharmacotherapy, about a patient called Hassan, who comes to consult you with his daughter, and you're talking about possible CBT and perhaps some antidepressant medication as well, because that's been useful for him in the past. So phase 3 then was the trainer program. So if people have gone through phase 2, signed up, were interested, we enrolled them in phase 3, which is a detailed course designed to equip trainers with the skills to teach and implement the MDD Minds curriculum in various settings. And we were aiming there to train 150 participants, enhancing their understanding and their dissemination skills. Of course, there was an online content, but also real-time sessions, either mostly online, but sometimes face-to-face between trainers, between master faculty and the training group. There were 4 sessions with master faculty, one of which was a scholar's choice, where the trainers decided what they wanted to know more about. And then each trainer was asked to deliver at least one local training activity once they'd completed their bit of the program. And then in parallel with that, phase 4, we called performance in practice. This was about applying theoretical knowledge in practical settings to improve skills and proficiency. And the implementation was more specific. It was across 6 practices, 2 within each region, and the aim is to evaluate real-world application and outcomes. The focus here was, could have chosen many things. We chose depression screening for patients with diabetes, because that was a group of patients that were probably easily recognized in general practice settings. 12-week project, analysis at swim lane to see who within a practice team was doing which jobs, and so you can work those out based on a plan, do, study, act process, and there was a 2-cycle improvement process during that 12 weeks. Pretty intense, actually. And so this is where we are now. So policy development and scalability, we are right today here, and point 1 here, project results, reports and publications. And then we're going to be looking with you and in the future about translations and adaptations in other languages and settings. Okay, so I'm just going to give you one slide, which is the most headline of headlines. You'll see this again, and Mary and Christos and everybody else will be examining these in more detail. But this is just the headline one. So top of the page, the countries: Kenya, Nigeria, Saudi Arabia, Indonesia, Japan, Sri Lanka, Brazil, Mexico, Peru. And in terms of numbers, so almost 3,000 family physicians enrolled on the MDD Minds online education program, of whom 581 completed it. Train the Trainer workshop, 12 master faculty providing the workshops in all 9 countries. We enrolled 210 scholars, of whom 126 completed it. And they, in turn, delivered 143 sessions locally to almost 1,700 learners. And then at the same time, the performance and practice program, actually 7 practices were involved rather than 6. And more than 1,000 patients with diabetes were screened for depression in those 7 practices. What all that means, well, basically what it means is we did what we said we were going to do. But what it means in detail, you're going to be finding out and discussing and exploring in the next few hours. So my conclusions: WONCA can and has delivered a high quality education program at scale. Family doctors, and you'll see more detail, family doctors as a result do increase their knowledge, skills and confidence in addressing depression. There is a positive impact on patient mental health and well-being. And perhaps most importantly, this approach is replicable and sustainable. So that's me. So I'm going to stop there. I'm going to sign out. I'm going to wish you all the best for a fabulous day. I'll be around sort of on the the live feed, but I may be able to make some chat occasionally, but I won't be directly involved in discussion. So have the most fabulous day, and I wish you all the best. Bye for now.
Dermot, so before we continue the day with specifically focusing on the project, the results, I would like to take 5 to 10 minutes just to give you how this connects with WONCA and how you all have helped start the transformation of WONCA. So, yes, almost there. Thank you, Dermot. Awesome, fantastic. So, we are WONCA. We are the World Organization of Family Doctors. We have a mission which is to improve the quality of life and the health of the peoples of the world. And how we are going to achieve that through a strong family medicine and primary care. We have a global reach. We have 134 member organizations in 7 regions, representing all the regions of the United Nations and the WHO. Dermot, perhaps the... Yeah? Fantastic. No? Once more? Okay. Yes, almost there. So our key focus areas, if we can distill what we're doing, are these 3 things. Our expert groups are working together on knowledge exchange. We are supporting them through online virtual communities of practice, but also through conferences. We are working on capacity building through projects like the MDD Minds, but also through setting standards on education and quality and safety. And finally, advocacy. We are an organization in official relations with the WHO, the Pan American Health Organization, and many other stakeholders on the global primary healthcare field. These are our expert groups. We have a plethora of groups of experts coming from all over the world, and they're bringing their breadth of expertise to advance family medicine and primary care. And of course, the Working Party on Mental Health is one of them, but you can see the variety of topics, which is an example of what primary care really means. Now, the MDD Minds is, as Steve, our treasurer, mentioned, is the first big project that WONCA runs. And how this connects, why this is so strategic for us. Our strategic plan of 2023-2027 had 3 goals. And within the 3 goals, you will identify achievements from the MDD Minds project. So the first goal was advancing family medicine through research, education, and advocacy. And with the MDD Minds, you help us enhance clinical knowledge, connecting participants from 9 countries, and also developing leaders and the future leaders on major depression and mental health by extent. The second goal was one unified voice, so WONCA leading as one voice for the family medicine globally. And you have strengthened how WONCA's position in advocacy. And you helped us to showcase the message that it's all about primary care. It's multidisciplinarity. It's not only family physicians. It's everybody, all the team of the primary care coming together. And finally, you have helped us transform WONCA, because thanks to this project, it's the very first time that we are working in-house to deliver something. We believe we have the opportunity to scale up and to replicate and to address other health priorities through a blueprint that we have created thanks to this project. What is this blueprint? It's the MDD Minds project. So you will recognize out of these 4 phases how we want to work on projects for WONCA on different other health priorities, healthcare priorities. So we start with a needs assessment that drives a curriculum development. We then have a direct-to-physician course development, which is the MDD Minds one-on-one program. And then a train the trainers phase, where we build capacity for the future leaders, those who will be in the field, in their countries, to build capacity for the future of on specific health needs. Quality in practice is an important part. We want to see whether we brought about change, we improved care. It's all about our patients. And no project should end there, because every project should drive policy development. So out of every of our initiatives, we want to develop recommendations for policy, because for WONCA, it's important to drive those messages back to where policy agendas and decision-making in healthcare takes place. And indeed, we have started working with our working parties. Dermot, may I ask you the next slide? Yeah, perfect. So we have project proposals right now on human factors, on climate change and air pollution, on digital skills. Next slide. It loses focus probably. And on family violence. So these are all projects that are based on the same concept of the MDD Minds project. So think about this. You have been leading what WONCA can do, and other groups, the other 27 groups, can do within WONCA. So what's next? As also Professor Chris Dowrick told us, it's dissemination, it's policy. You will speak of this today, but it's also scaling up. We will hear about this in a few moments, scaling up to other regions, scaling up to other conditions, and replication to other contexts. It's a big thank you, my last message. It's a big thank you to, first of all, the master faculty who made this happen, and you all traveled so much to be here in the final event. A big thanks to the 3,000 participants who enrolled the course, and to the many others who participated in the live sessions and the trainer and the quality in practice phases. A big thanks to the in-country leaders, our donor, Pfizer, who supported us with an unrestricted, unconditional educational grant. I would also like to thank our partners, Mosaica Solutions. We have today Sally Rodriguez and Mary Ailes, who will be speaking, and we couldn't have made it without you. And finally, thanks to the Working Party on Mental Health. Professor Christos Ioannis is the chair. And Professor Chris Dowrick, of course, the former chair. And finally, to WONCA, because WONCA believes in mental health, is promoting integration of mental health in primary care. And thanks to WONCA, we are here to showcase the highlights of these projects. Thank you so much for being here.
Thank you very much, Dr. Ligidakis, and dear esteemed honorary treasurer, dear colleagues. I think it is a unique opportunity for myself on behalf of the steering committee, on behalf of my closer friend, Chris Dorick, and also all the partners and friends from both WONCA Working Party and then also from the faculty members, just to introduce a key session at the moment, which are actually our strong colleagues, if we're saying colleagues, of course, and partners from Mosaic Solution and Mrs. Mary Alice and Mrs. Shelly Rodriguez will start in presenting exactly what we achieved. But just in the next 3 minutes, I was thinking, our colleagues, which is the time where this MDD project has implemented. Potentially that will be some challenges that Mary presented the report will give in some more highlights. First, 5 especially key issues in terms of the time of the current situation where exactly the project has been implemented. The first, MDD comes in a time where world is changing. A second is in a time where many societies affected by multiple crises were still evidence of a COVID pandemic, but we're having a migration-induced crisis and climate change. The third, in a time where healthcare systems struggle to meet the over-demand of healthcare services, but also enormous healthcare inequalities across the world. The fourth is a time where compassion fatigue and burnout is a growing issue among the family physicians and frontline practitioners. And at the same time, depressive symptoms are highly prevailing among adolescents and young adults. And the fifth related to reason is a time where many stakeholders claim that primary care is not sufficient. And also, that's many other, they asking more evidence and just improving or saying that the family medicine and primary care is effective. I think there are 5 particular reasons explain why MDD just implemented. And I suppose that responses to these 5 challenges could you find in the excellent report that our colleagues, our partners from Mosaic Solution has prepared. And it's a pleasure and privilege for myself in introduce Mary. Start a little bit giving more highlights about the report and of course additional messages from the website is coming and many testimonials in giving additional evidence. Mary, please. Thank you.
Thank you all. I am Mary Alice. I am the partner in Mosaica Solutions with my co-partner Shelly Rodriguez, who you will hear from a little bit later. What we would like to do is to give you an overview of this project, how it was designed, the science behind that implementation, the background in education, as well as the results. We'll end then with hearing from some of our learners, both through their stories as well as videos, and introduce you to the MDD Minds website, which is available now with many of the educational resources that we've discussed. I want to start out with another picture. It's a little different than the one Chris showed you, but I want to start with what our ultimate goal was and how we got there. We begin by thinking our goal is to build capacity in mental health within primary care. So we start, we start here. And what we did was we engaged in country-based train-the-trainer learning. This education that we started with here was really driven by knowledge. We wanted to make sure that everyone participating had a foundation of knowledge with which to carry on the skills and action needed to change behavior. We then engaged in country-based training through train-the-trainer learning. And what this allowed us to do was to localize that knowledge. The global education was the MDD Minds 101 class that applied to everyone throughout the globe. The local education was the work of the trainers that happened through a multi-phased education that was held that encouraged application locally, but also connections. Who are my colleagues? What are their challenges and struggles? And how can we move forward together? From there, we moved, I'm gonna get this right yet. There we go. We moved into spread. How is it that we spread the knowledge that we have? And through that, we asked our trainers, newly trained, to go out and share the MDD Minds story within their own local communities so that others learned and understood the application of this knowledge within their own work environment. And then what we asked to do is to move this to practice-based action. We could call it quality improvement. We called it performance in practice. But to say, how do I take the knowledge that I have, the skills that I've learned, and apply it within the family medicine primary care setting where I am? And finally, what we do with that practice action is move towards this goal: improving the health of our patients, improving their livelihood, improving their happiness and their satisfaction with where they are. And the role of family medicine, of primary care, is to help each individual live their life the best way they can. So while this project started out here to build capacity, we together, through a variety of educational strategies and improvement, came to improved patient health. This is what we affectionately call our brag sheet, to tell you a little bit about where we've been and what we've done. Consider it your family photo album that you leave on your coffee table to share with your friends and family. We've had, as Dr. Dowrick said, over 3,000 family physicians participating in this program in one way or another. We had 581 complete the online curriculum. I entered this project as an educator, and to have 500 people complete an online education program without, other than some nudging, but without any other reason to do it, but the desire to learn is really quite astounding. From that, our master faculty moved forward in their 9 different countries. We had 210 scholars who had completed that initial education enroll in our Train the Trainer program, which is again a phenomenal number, with 126 of them completing the full program, which involved 4 online learning sessions, as well as delivering this education locally within their community. Again, because they saw the value in improving care for their patients. Those scholars delivered 147 sessions to my number's a little higher than Dr. Dowrick's. We're now up getting close to 1,800 people who have participated in this, and we'll talk about who those people are in a minute. Then we had 7, and I actually think the number's 9, practices participating in the performance improvement portion, where they were actually able to go and screen over 1,000 patients for depression. So we've had 1,000 patients as part of this be evaluated and engage with their own family doctor about how their mental health affects their chronic disease. So welcome to our family, our brag sheet, our photo album, and let's take a look inside and see what's there. As Dr. Dowrick said, we worked in 3 regions. Some of this was to understand how our global education could be localized. And it was a little different in each of those regions and indeed in each of those countries. But we've learned from and with each other, and the master faculty have been able to share their stories. How did we come up with this? We really used an implementation science framework to structure this program. We began by assessing what are the evidence-based information, what is it that family physicians need to know, and reached out to stakeholders for engagement. And those were the local chapters of the WONCA organization that brought us members and engaged with us in those conversations. We prepared adaptations. What will work? How can we distribute it? What are the logistics behind implementing this work? And then we took those theory and that implementation, looked at frameworks. We looked at the quality improvement framework. We looked at implementation science. We also looked at what we know about adult learning and how people learn. It's never from a single event. It's from being engaged in a community, and it's from practicing the work that they do. And then through that, we evaluated this program. There's our hundreds of pages, literally, of data that we've looked at, we've shared with the master faculty, and we'll continue to evaluate that data and look for publications so that we can share with others what the impact of this was. And then we come back to the beginning and say, we want to contribute to the body of knowledge so that others can implement either the process that we used or specifically the curriculum for looking at major depressive disorders within family medicine. This was an integrated curriculum. And by that, what do we mean? The topic, the subjects along the left here are basically the modules or the topics that we wanted to discuss. And then you'll see here in the middle what topics were covered and where we went with all this. And what I want you to take away from this slide is the progression of this. We didn't try to do everything in performance and practice that we taught in a basic curriculum. We really, at that point, were focused on screening, because in performance and in implementing it in practice, it doesn't make sense to start with treatment until you know who your patients are. So rather than try to do everything all the way through, let's talk specifically about the skills and the opportunities that family physicians have to change what they do in practice. I want to talk a little bit about the tools and resources. Let's see if this is going to go. Maybe. Oh, yep, there we go. We developed well over 50 resources as part of this. We begin with what are the comorbidities, or we did a session on comorbidities. See if you can, I don't know if I'll go on click or, sorry. There we go. Talked about cognitive behavior therapy. These are just some examples of the ones that we're looking at. Next. We shared depression screeners. What screeners are available? We were looking specifically at ones that had been translated into multiple languages and could be used natively. Those were valuable resources that our Train the Trainers used. Go ahead, next. Quality improvement. This is a data collection sheet that we used as we worked through baseline data, cycles of improvement using a modified PDSA cycle, looking to final measurements, and we'll look at some of those data specifically shortly. Next. And this was our platform. We used the Trello platform, which allowed us both as curriculum designers to populate this, but more importantly, it allowed the faculty to go and add their own content there, where it would be localized to what they were doing. It also allowed our participants, those trainers, those scholars as we call them, to add their stories and comments. So it became a rich repository of the stories and progress of this initiative as we moved forward. Technology, as always, can prove some challenges. It means you need a device with a connectivity that will work. It also means that we need the skills of people to translate, to be able to move from, again, what is a global look into a local implementation. Keep going, you can keep going with that. I want to stop on this one. This is an animated video here in Japanese. We felt it important to develop some tools and resources that were designed not just for the physician, but for the healthcare team, and felt that one of the easy ways to do that was through small animated videos. So our master faculty once again stepped in and localized these videos so that we have them in Japanese, Portuguese, and English as well. But that, again, that model setup of this is not done in one language, but it's really localized to the place where that learning it needs to happen. And we base this is the Lancet Commission article. This is where this comes from. This is the foundation of the work that we're doing and the advocacy effort that goes with it. Let's talk a little bit about addressing knowledge. Okay. I think I should be back in control now. There we go. Who learned? What was happening here? We had most of our completers were from Brazil and Saudi Arabia, the largest numbers of up there. The average years in practice was about 8. So these were younger learners who were newer in their practice, average age of 38. So again, we were looking at a younger population. That's exactly who we would love to reach, because they have a foundation in the work that they're doing, and now they are honing their own mental health skills in working with their mental health. Most of them came from community clinics. Most of them categorize themselves as living as an urban environment. And most of them were, the majority were female. It varied a little based upon the country, but we did see more women learners than we did men. They were generally a little younger as well. I can go through tables and tables of data, but what I want you to walk away with is that the average confidence scores from the beginning when they enrolled was 3.0 on a scale, Likert scale of 1 to 5, which is average, right in the middle. Some better, some worse. By the time they were done with this 6-module 101 education, they had raised their confidence to 4.11. Now that's just a number, and I know that, and this is statistically significant. It's just a number. But to have doctors feel confident that they are able to go and address the needs of their patient is invaluable. We know from work we've done and from the literature that if a physician is not confident in their ability to diagnose and treat, they are less likely to diagnose it. So the act of increasing confidence alone gives a physician the ability to go and take that forward into their community. We also wanted to look at what the intended changes were And these represent, I believe, 986 changes from these people that had completed an hour-and-a-half online education series. Granted, it was a great education series, but it was still an hour-and-a-half worth of education. Non-pharmacologic education was their largest takeaway. But let's look at what was second. The second was self-care and provider wellness. I go back to Dr. Leonis's comments at the beginning. Burnout is real, and overwork, the challenges of family medicine are there. So to be able for them to walk away with a personal sense of hope was a valuable outcome of this project. They also looked, then number 3 is patient-centered care. And then you get to some of the clinical components, screening and diagnosis, pharmacologic management, follow-up and monitoring. And at the bottom, collaborative team care. And as we discussed this yesterday with our master faculty, their comment was, that's the seed that needs to grow out of this project, is being able to work with our healthcare teams and other professions to move this forward. Let's talk about localization and spread. As we mentioned before, what we did is we asked the master faculty to take on lead as trainers working within their community. And each of them stood up and entered into that conversation and that request with gusto. We had scholars from Mexico, and what you'll notice if you look here is some of them are very large, have huge, I go back to Saudi Arabia and to Brazil. Brazil had 928 learners out of 30 scholars with 60 sessions. So a rich group of WhatsApp discussion and creating a community. And Mexico had 2 scholars with 4 sessions. And you might not feel so good about that. And then you look within that, they had 135 learners. So the ability to make a difference wherever you are, it is no different. Each one of these master faculty that I have the pleasure of looking at as I'm talking made a difference in their community and started making other future leaders as they move forward. We could go through this detail, but we're going to leave it at that. I want to talk a little bit about the interprofessional nature of this. This represents one of those sessions from Mexico, and we found that I think it was 28% of the learners in Mexico were not physicians, but rather represented other healthcare professionals. The same was true in Nigeria, where Indonesia, where 32%. We educated nurses and midwives, and you think about major depressive disorder and postpartum symptoms, what an opportunity to share that. And that was true across the board. So it goes back to Harris's comment, we are looking not just at the physician, but how the team is able to care for the individual. We also asked them, how did this project allow you to care better for yourself? And what we see is improved screening and diagnosis. Again, you can't treat what you haven't identified. And enhanced pharmacologic approaches were the largest piece. And we hear that theme again and again. It's knowing what's in my community. Then your number 3 there, increased confidence in management. So all through this, while we've addressed knowledge, we've provided skill, we've also addressed attitude. And we know from education literature and change literature that addressing attitude really becomes the foundation of how you move change forward. This is our practice-based action or performance improvement component, where, as we said, we've had over 1,100 people, total patients with diabetes screened. Why diabetes? Dr. Dowrick referred to it, because you all know who your diabetic patients are, and they frequently come into the office. So when we asked people to do this in a 12-week time period, at some level, diabetes was a convenience, but we also know patients with diabetes, with chronic diseases, are at increased risk for depression. So we found these, what we've got down here at the bottom are swim lanes, just written down. Who cares for what? Who does what in a practice? And how can we use that to improve? We have photos here from our practices in Brazil, which include a team up in the top that was so grateful for this opportunity because that team had lost someone to a major depressive disorder. And so for them, this was meaningful, not just for their patients, but for their own healing and focus on mental health. The team below that here determined to use community health workers and realized that they were a valuable reach into the community. And then our last team here, again, bringing everyone together to work, dentists, community health workers, nurses, the whole team being involved in the work that was done. What is highlighted here, 22% of diabetic patients were identified with depression. And that's about within the range what is seen in the research literature. So what we're seeing in this community, in these communities and in our own improvement work is really echoed in, or we are echoing what is in the research literature. A data chart, because you all need a data chart, and just an idea of what this plan looked like and how we asked our faculty to work through this. Organized in calls and baseline measures, wrap up, and cannot thank them enough for their implementation of this project. Let's talk a bit about impact, though. We asked the scholars, and I realize there's a lot here, I'm going to help you through it, to tell us what they received from this. It's the multifaceted dimensions of mental health, an environment of collaboration, learning, and innovation that they walked away, a deeper understanding of the challenges faced by my patients. I met with like-minded other professionals and created that bond that way. And then the tools and resources allow me to provide a holistic approach to my patients. I'm reducing stigma and looking at early intervention. And it's empowered me to advocate for mental health within my own community. There's not much else to say after you read that. There are also people that talked about changing my practice. We've transformed delivery of care in rural facilities because now we have someone trained who can go and start that work. I'm implementing shared decision-making, getting away from a paternalistic approach to my patients. In green, I can now explain non-pharmacologic interventions with families and patients. And then to the right, it helped me to take better care of me and to connect with my other Peruvian doctors, to share ideas. So their words are so strong. And then from the performance and practice people, I was able to care for patients with diabetes. We used the PHQ-9 tool. I could evaluate this, and I was able to use it during consultations. And the idea that other professionals can use this was very important. I am happy today to stand on behalf of the WONCA team and introduce you to the new launch of the MDD Minds website, where you will be able to find many of these curriculum modules that we've talked about, the stories, the testimonials. So I encourage all of you to go to mddminds.org, and not while you're in this session, but later, and take advantage of the resources that are there. And this will be a place where ongoing learning, links to publication, as well as some of these testimonials will happen. What I'd like to do now is stop and introduce you to a testimonial video. These are of learners from 101, and we'll just take a moment to load that up. Thanks to this tremendous AV team that allowed me to change the flow of this presentation at 9 o'clock this morning. So hang on.
Hello, my name is Dianda and I'm now working as general practitioner in Indonesia. Hello, my name is Dianda and I'm now working as general practitioner in Indonesia.
I'm Dr. Sulaiman Afatah Afolabi, a family physician from Nigeria.
My name is Mary Karam and I'm a family medicine resident at Halwain University in Cairo, Egypt. Hello and selamat pagi. I'm Dewanto, family medicine trainee from Indonesia.
My name is Dr. Itayo Adumo. I'm from Nigeria and I'm a consultant family physician.
My name is Helen and I'm a primary care physician practicing in Indonesia.
I'm Fatusim Bolatito. I'm a clinician and trainer in family medicine.
My name is Ana Lewi Santoso from Surabaya, Indonesia.
I'm Mohammed Al-Amin Mukrim, consultant psychiatrist and assistant professor of psychiatry in Arar, North Central Saudi Arabia.
Dr. Eli Nyodoramede, a chief consultant family physician in Nigeria.
I'm Dr. Kushid.
Victoria Olafimiho.
Milena Erfa.
Liz Wanjiko, a clinician from Kenya.
Maitri Rupasinghe, I'm from Sri Lanka.
Olá, sou Ana Milka, médica generalista, atuo na atenção básica no Brasil.
I'm Dr. Harun Taufik from Sri Lanka. I'm a family physician and I completed the WONCA MDD course a couple of months back.
The MDD Minds 101 course from WONCA gives me practical insights and strategies for managing depression across 7 modules from diagnosis to patient care.
What I liked most about the course were the case examples, which were so relevant to our daily family medicine clinic practice. It made the course applicable to the patients that we actually see, and not just theoretical knowledge that's harder to apply.
MDD 101 is a course I enjoyed because of its simplicity and practicality, especially in understanding of the non-pharmacological approach of care for patients with depression, and this knowledge has improved my outcome with patients with depression that I've managed.
What I liked most about the MDD Minds 101 course was how well structured and practical it was. The content was easy to understand and directly applicable to my daily work.
And this course has helped me identify MDD earlier and also how to treat the patients with depression.
After taking the course, I was motivated and because of the practical examples, and this has helped me to help better manage my patients.
The program is available now. I have a better understanding of cognitive behavioral therapy and other non-pharmacological management of depression.
Truly valuable. By engaging with this course, I have acquired a deeper understanding of mental health issues, which is crucial when caring for patients facing such challenges.
The MDD Minds 101 course has simplified the concept of major depressive disorder. It has helped me to be more adept and proficient in the management of major depressive disorder cases.
It really impacted my practice because it gave me lots of knowledge on management of major depressive disorder.
What I like about the course was the practical approach that made complex concepts easier to understand.
I had a very nice experience with MDD Minds as I supervised the program of incriminating psychiatry and primary care here in the northern border, and it helped me very much in handling the doctors that I'm supervising, and I recommend it for any primary care doctor or any family physician.
A abordagem sobre o transtorno depressivo maior é de extrema relevância para a prática clínica e eu gostei muito do curso. As reuniões online foram incríveis, me possibilitaram uma rica troca de experiência com os outros participantes e também com o moderador do curso. Esse aprendizado ampliou muito minhas possibilidades de intervenção e ajudou a evitar os encaminhamentos desnecessários para uma atenção especializada.
I'm dealing with more patients who are having somatization and mental health issues. I'm getting positive feedback when I am approaching the patient toward that way. Thank you.
I definitely recommend this course to colleagues because it equips you with the essential to improve patients' outcome.
Because as first contact doctors, we see this patient first, and this knowledge will enhance our care delivery to them before referral even when needed.
I highly recommend this course for everyone who is interested in helping fellow humans deal with someone with depression, because this course really helped me. It was easier to understand and practice it. Thank you.
Thank you to the WONCA staff for assembling all those, and we continue to look forward to more testimonials as we capture them from those who've participated in other portions of the program. So I wanted to end with just 2 quick slides. We know from this project that family doctors and their teams play an integral role in the patient, their patient mental health. And that from this program, we know we need to advocate for integrated mental and physical health. That's what WHO tells us. It's what we know. It's why all of you as physicians are here. And we know that we are addressing the mental health of family doctors and their teams, where that continues to be a challenge and a struggle, and they're taking these resources and being able to use them internally. And we know that this is also part of a global education and improvement initiative through WONCA that will be expanded through not just mental health, but through other areas to improve the reach and the practice in family medicine. But ultimately, this is about improving global health equity. It is about caring for patients one by one and allowing every individual to live their life to their fullest and making sure that that is done equitably throughout the globe. So thanks to all of you faculty who participated in this, thanks to WONCA and the ability to do this, as well as to Pfizer for recognizing the need to address health equity and using depression, major depressive disorders as that example. So thank you very much. We have 5 minutes for questions. Sorry. We would encourage anyone who's on YouTube Live, we will have a question time later today where we'll be able to engage with you. But for now, any questions from this audience that you would like to ask about this project or this presentation? As I said, we will have time for questions later.
I was particularly delighted to see the age of the participants. That seems particularly successful to get a group of early careers doctors who are established but not sort of coming towards the end of their lives as family physicians. How did you do that? Was that a targeted thing, or was that just good luck?
I think the answer was it was good luck. One of the slides that we didn't show, we talked about with the faculty yesterday, is the use of social media and WhatsApp and community, those more informal community networks as a recruitment tool. The other was word of mouth and suggestion perhaps by a senior faculty that someone should enroll. So it became really, and I think most of those individuals that were on the video were younger physicians looking to expand this. So, and I'm going to give you now someone who was part of it there.
I think also the young doctors movements help us. For example, in Wainakai, also in Asia Pacific, isn't it? Yeah. I think that was a good effort of the young doctors movements also.
And also cost effective. So, that's a very cost effective way of reaching out through social media networks. My current resident, my current trainee with me has 9,800 followers in the UK. Someone like that, they reach a lot of people very quickly. Amazing, thank you.
I answer a question in the back. I will also add that I think of this as an educator, and now what resources do we need for distribution on WhatsApp and these other social media platforms? It's different than perhaps how we might have learned even 5 years ago and how we might have connected. So I think there's a huge opportunity to adapt to that.
First of all, I'm really excited about the launching of the new website so that all the materials will be made available to the general public. And but what I want to ask is whether we can still expand further the online course of MDD Minds 101 to include different languages or different countries. Since Indonesia is very excited, me and Darian wanted to endorse this to the Minister of Health to become one of the primary program, and also introducing WONCA in the process, so that it could be a national program, but maybe we'll, if it's possible. Thank you.
Very happy to support. Yes, sorry, thank you. A wonderful idea of how to put in practice and to further support capacity building in different countries. Very happy to discuss on this. Thank you.
Yeah, thank you all. Regarding the resources, it is not only saving the time, or it is also health resources in the countries. They become safe the time, the money paid for that, number of patients becoming less. Doctor have even start to cure himself. 60%, it's not easy. And the good thing, really, when I talk with Bahrain Family Doctors Institute, and they becoming aware about this project and how they empower the primary health doctor and family doctors work, he said, see, we don't want just to train. We want to enforce that in the curriculum of family doctors. This is the main thing, because if we just take the doctors who is graduated only, I think the postgraduate family doctors programs worldwide, they should enforce that. What is going now, if you talk with them, they said, yes, we have 3 months that family doctor will spend training in psychiatry. Yes, he spent working in psychiatry, but not in mental health and family doctors or primary health care. And this is approach is going toward the primary health care regarding his situation, the cases where he come, easy approach. Should we give more also the postgraduate training, more weight and concern in our target populations?
I think that's continue such an important discussion, and that as Professor Al-Khatami already said. We have, of course, later on a 10-minute session on sustainability, but I think that's idea needed to be invested more. That's see how to incorporate in the family physician curriculum, but also, as I said by yesterday, European Commission and is supporting now European members and giving money from a very big project on resilience, and giving opportunity to retraining now, that's continuous professional development, and retraining family physicians, especially on mental health, is a big issue that potentially we discuss and invest. Thank you.
I think we are time. Roberto?
Yes, we are already on time for the coffee break, but before we go on that, I just want to mention again for all those who are watching us on the live stream about the website that you can go there, and now all the resources that we prepared that are product of the project for MDD Minds 101, you can go and watch them. They are publicly accessible in the languages that we produce them, which is in English, Spanish, Portuguese, and Japanese, as well as with some downloadable resources, additional further reading for you to dig deeper into the subjects that we cover. And also you are going to find there the testimonials, where you will be able to see the stories of from the doctors all over, the participants all over the world, and connect through those testimonials and get a hint of how we touch the lives of so many people through this project. So we hope that you will find the content useful and that you will make the most of it. Thank you.
About like the launch of the website. So now actually all over the world, people can log into this website to learn that 7 modules at their own pace. I think that's very impactful. And I encourage everybody to go back home to disseminate that to your member colleges, your colleagues, your trainees, your other doctors. So, I mean, and I think to have that accessible to everyone who's interested in mental health will be tremendous. Yeah, thank you very much for doing that. Yeah. Thanks, WONCA, for making that possible.
Right, so let's have a coffee break. And we are back at 10.
Okay, welcome back. Those of you who are live streaming with us, thank you for dialing in and spending time sitting in your offices or your homes or your schools or your libraries listening with us. We will have an opportunity for you after our lunch session to actually participate as a breakout group to talk about some of these issues and to give us your recommendations and your thoughts and your feedback. Our next session is actually your opportunity to hear from 4 of our master faculty members who are going to talk a little bit about what they did in their countries. And I'm Shelley Rodriguez with Mosaica Solutions, and it was our great honor to get to work with all of you and to get to spend time with you and listen to you teach and see the excitement in the students' eyes that you generated. I would hope that during this session, you live streaming and you in this room will be curious. Will think about questions you want to ask, to think about challenges you are having and how we might help you solve those. We have note cards for you to write down questions that you want, and we'll gather those and try to get those answered for you. But I really would like to start with 4 of our master faculty members. They all had very different experiences, making the content their own, working with physicians and teams in their countries, working through both the Train the Trainer and performance improvement, and actually touching patients' lives, which is what this is all about. So I'm going to start with Andre Tavares from Brazil, who's going to begin the session talking about the very large cohort in Brazil who have joined us for this project.
Thank you, Mary. Good morning, ladies and gentlemen. First of all, I'd like to say that it's a really honor and I'm really grateful to be representing Brazil and to be part of this wonderful project. I'd like to thank especially to Professor Dr. Sandra Fortes and Professor Dr. Chris Dorick for this invitation, and also WONCA to being part of this. Yeah, my name is André Tavares. Nowadays in Brazil, I work most as a psychiatrist and psychotherapist, but I have a nice first journey as a family and community doctors working in a rural zone. And I just couldn't take family medicine out of my heart. So I keep working in teaching programs for family doctors. And I also study collaborative care on mental health. Yeah, it's still in my PhD on bioethics. So a little introductions. Do I have something for the slides, please? Thank you, Roberto. So, quick introduction. Yeah, in Brazil, we have a universal public health system we call SUS. Yeah, that's based in primary care with our health family strategy. Although we have more than 500,000 doctors in Brazil, just 1% of them are specialized in family and community medicine. Yeah, that's a very small number, and that makes programs as MDD Minds even more important, as we have to build capacity, not just with our family doctors, but also with a large number of doctors that are in primary care. There are not even family doctors. Another point is that half of these doctors are in the southeast region. That's where Rio de Janeiro and São Paulo is. And we have very few doctors in the north region where Amazonia is. Yeah, so we have a big country with big inequalities and big deals to solve. Yeah. So I'm engaged in the project since 2022. Yeah, we have a first step with the Latin America assessment when we have an expert advisory panel. And then we jump to phase 2 when we have MDD Minds 101, and we have more than 155 doctors that finished the program, and that the course received very high positive evaluations from these doctors in this phase. So I led the phase 3, that's the Train the Trainer course. We had at the first moment 65 doctors enrolled. Yeah, we decided to have the meetings at Thursdays night. That was the first challenge, yeah, to find a time that could suit most of them, yeah, as they work and they couldn't be away of their works. We had problems because sometimes they were on duty at night too, yeah, but we have always a good participations, very nice discussions, and we had the support also for a WhatsApp group. Yeah, in Brazil we use a lot WhatsApp, more than I like. Yeah, but that's a reality. It facilitates a lot, even the educational programs. We have and also the support of Trello board. We started discussions in Trello that worked very well. Yeah, they participate a lot in the discussions on Trello board. That was another particularity that we made. For each session, we made a good Google Forms evaluation. So after each session, we could improve what we were doing online, yeah, and also discuss, yeah, between the meetings about the replications and the doubts that they had. Here are some screenshots from our WhatsApp group, the discussions in the forums from Trello, yeah. They were very close to me, making phone calls, sending messages, sending emails, asking for another materials, bringing some doubts about the patients that they were seeing. So it was a very nice experience. Here are some photos of the replications that they made. Yeah, I think that was our best results. Yeah, we have 41 students that really started the course, and from them, we have 30 that were approved, that were the ones that really made at least one replication. Yeah, there's something that caught my attention just when I was making the slides, that we don't have that we had no doctors from North and South regions. Yeah, there's something that we must understand and maybe focus in the next steps. And I received 6 and 8 reports, yeah, from the 30 students. There were students that made even 5 replications. We had 82 hours of face-to-face trainings. All the trainings were face-to-face. We had no virtual trainings during the replications. Yeah, that was a nice point too. We have almost 1,000 participants. Yeah, a third of them were doctors. Yeah, but we also had nurses, psychologists, community workers. That was also nice. And some results, yeah. In the evaluations in Google Form, we have very positive evaluations too. I could not bring all of them to you. Yeah, some good aspects was the engagement in Trello, in WhatsApp, the active discussion, and especially the replications. And some areas for improvement is that maybe we should have more publicity and incentives for them to participate, as we have a large country and many doctors interested to participate. An additional tutor would help also with smaller groups and role plays. We decided not to do role plays online because it would be difficult with such a large group. And also face-to-face activities, especially in train-the-trainers. So here are some testimonials. I will not read them to you. I would just like to highlight this one here. Because something that I noticed a lot, as we said today, yeah, as Christos and Mary, about the burnout and the exhaustion of our doctors. Yeah, always when we have a course that we talk about mental health, there are some doctors that come to me and say, hey, I discovered that I'm depressed, I discovered that I'm with burnout, yeah. I also led phase 4, that was performance in practice. We had 2 experiences then, one in Rio de Janeiro with Dr. Alfredo, and one in Ceará, in 2 cities, to tell you the truth, with Dr. Magda. We also have 4 Zoom meetings, also had the support of Trello, WhatsApp group, phone calls, emails, just as in Train the Trainers. The first experience in Rio de Janeiro was in the capital, yeah, in a zone called Irajá. They had the experience from August until December. They had 3 doctors and 2 nurses in a urban zone, yeah. And something that caught my attention is that they already had a screening process, but just screening 5% of their diabetes patients, and they increased it to 40%. Yeah, and from the patients that were screened, they had a positivity of 15%, with a total prevalence around 33% of the patients with diabetes that that had depression too. He has some pictures of the team and from the health unit. And another experience from Ceará, something that called our attention, is that we have 2 female teams, yeah, as we discussed, yeah, yesterday. We have a lot of women. It's an increasing number in Brazil. We have 2 teams, one from Pacajus, that's a rural zone, yeah, as you can see in the picture of the health unity, they have very poor conditions of work. The other one is from Cascavel, and it's an urban zone, yeah. Here we have community workers, all female too. We put the data together from the 2 teams, okay? They had the experience from September to December. They had no screening process, yeah, and they increased the screening to 70% of the patients. It was a really big increase, yeah, and they have a 17% of positivity, very close to Rio de Janeiro, and a prevalence of 25%, very close to, yeah, as in the literature, we see that's 20 to 30%. And something that also called my attention is that they give tools for more patients than the patients that were diagnosed with MDD. Yeah, there were some patients with emotional suffering that were not with depression, but could receive non-pharmacological interventions and also benefits from the project, okay? That's a testimonial from one of the doctors, yeah? She had no integrated view when she was attending the diabetic patients, and after the project, every time that she sees the patients, she thinks about mental health and all the stuff that we are discussing. Some testimonials, yeah. I highlighted this one because that's Alfredo, some of you might know him, and he told to me, Andre, I thought the doctors will not attend the project because they are overloaded, and he said he was very surprised because they felt that the project had a sense, yeah, and they were very enthusiastic with the project. So, for the next steps, we think we can present, yeah, MDD Minds project, also to governmental institutions and educational institutions, so we can offer it widely with greater publicity, yeah, and incentives for professionals to participate. That's a need of the Ministry of Health nowadays, and there's a very good idea for us to discuss. And as we are discussing to write reports, to disseminate the results achieved in Congress and publications, so we keep increasing the project. So that's it. Don't hesitate to contact me if you need any other further information. This is a city of my city in Ceará. That's Fortaleza, Northeast Brazil. Be welcome, someone, if you want to visit us. And thank you very much for your kind attention.
Thank you, Andre. And we have 4 faculty members, and at the end, we'll have time for you to ask questions from all 4 of them, and we'll have them up here to be able to answer questions from you. Next up is Dr. Ryuki Kasai from Japan, who has been working on this project from its very beginnings with a pilot that WONCA worked with us on back in 2018. So Dr. Kasai is going to share his experiences in Japan.
Thank you very much, Sherry. Okay, that one? Yeah. my name is Ryuki Kasai from Japan, a very small country to compare with Brazil. And the number of family physicians is very small also. And the certified family physician is just less than 2,000 to serve our population is 120 million. So a significant shortage of family medicine and its development. But we are very happy I'm very happy to present the story and journey of Japan MDD Minds for Primary Care program. Yes. And I'd just like to dive in the data we got. So this is for the MDD Minds 101 Japan, and the enrollment is 279, and the 52 finished. And in terms of gender, so the 35 male and 16 female. So this is the years in practice, and to compare with other countries. So our participants are older, maybe by 10 years or so, and you will see where I am. Yeah, in the graph. So this is the Japanese family doctors' demographic fact. So, but which doesn't necessarily means that we are far behind in terms of the popularity of this or enthusiasm to participate in this program, but rather I'm very happy that we get, and I can get the senior trainers in family medicine get interested in teaching, in learning how to teach mental health in primary care. So I would like to congratulate the senior participants in my country. And then I hope in 10 to 15 years' time, so those who attended the senior trainers will be more active in the field of mental health in primary care in Japan. And so their training background is that most of them are family medicine, family physician by training, and types of practice is the many are working in the private practice as well as hospital. And demographic setting is about the half is urban, and then suburban, and some the few rural doctors. And this is a self-assessment of their confidence. And yeah, here you can see that after the participating, after completing this course, that those who think that the very confident is very much increasing, and so those who are not confident at all are very much decreasing. But so we are very modest people culturally. So there's still the many continue to think that I'm not so confident, or I'm just moderately confident. But I believe that so their knowledge and skills and behavior and attitude and values very much improved by this 101 MDD Minds 101 program. So thank you. And this is the intended changes among the participants. And here you see the non-drug interventions and self-care and screening, the best, the three, the most changes the participant would like to make in the future. And in terms of my MDD Minds Train the Trainer project, so we got the 20 registered scholars and 9 completed, and then 5 conducted their community meetings, and 4 scholars are still planning. So they planned their community meetings, but not have completed yet. And you can see the geographic distribution of the scholars. And some testimonies. So they appreciate the multi-layered project. So they encountered a lot of trainers and the faculty members, and then also they liked the connection with the master faculty and faculty members and fellow trainees, and they had a chance to think about mental health and the importance of its effective teaching. So not only the practice, but also the teaching aspect. So they think it's valuable. And it was the good opportunity for them to share their situations and sometimes their problems, and so they are looking for any solutions by discussing and sharing with our team. So this is very nice. And then in terms of challenges, so there are many challenges, and yeah, some at some practices, other research projects are simultaneously going, and they are very difficult. And language barriers is also exist. And many of my colleagues did not fully understand, especially for example, the clinical staffs don't understand the English materials well, so they have some problems. And the scheduling is usually a challenge, and so yeah, the time constraint and juggling work and private life. And they have some suggestions to improve this project. And yeah, so again, the language problems, and also yeah, they want to have the sessions of free talking, just talk and share their experiences and so on. And the scheduling is they want the schedule a little bit more slower than we did actually. And someone wants to have open dialogue method as non-drug intervention. And the participants can post and discuss more easily, and yeah, so they want to have more larger networks, and they want to have opportunity to learn alongside the trainees and faculty members from other countries. And in terms of performance in practice in Japan, I purposefully choose 2 practices. The one in the Shiga, the left-hand side, the West Japan, and the other is the practice in Tokyo. And the practice in Shiga is established, and so they actually celebrated the 10-year anniversary. And the clinic practice in Tokyo is just the new one. And I'd like to, and then the setting is different, so rural in Shiga and urban in Tokyo. And also the practice in Shiga has experience to accommodate the trainees with them. And practice in Tokyo is just preparing for accommodating the trainees. So I'd like to encourage both of them. And then also I'd like to provide the chance to exchange each other, to improve each other. And in terms of the variable things, so the many members, so which means the many members at the clinic learned, and many conversation about mental health care happened within the practice, and staff awareness was improved, so they think. And the challenges, so they are busy, and and then also for them to screen the depression is quite new to them for the diabetic patients. So it's sometimes the challenge for them. And the suggestion is, so again, the language barriers, and so they would like to involve more clinical staff at the clinic to work with this project. And this is the so testimonial description on whole the project from 101 to train the trainer, and performance in practice. So here I see so the confidence level is increased, and especially in non-drug interventions, and then program was practical and rich, and so they would like to continue to brush up these skills with their staff, and they can have a more positive attitude before than before, and so they can strengthen their confidence to improve and training trainees. And then also they realize the importance of social participation and local resources. And so recently, the one article was published in the Lancet Regional Health Western Pacific, and I was one of the co-authors. And so this is a paper to reflect. So we tried to do the research in the community. It's a cluster randomized controlled trial on to see how the one and how a series of behavioral intervention work, but it failed because the recruitment was not successful, and we so we we would like to think, so why we failed, and what's the difficulties, and what would the potential solutions for us. And then I believe, so this is a very, the parallel, you can get the, okay. Yes. So why a primary care research in Japan is underdeveloped? So the first, that we have two major barriers, and one is we have too few family physicians. And this is the same, the why primary mental health in primary care has not been developed well in Japan. So we don't have many family doctors in Japan. And also this number one and number two barrier is the organ specialist dominated healthcare system. And so we have institutional and logistical barriers to primary health care, as well as the mental health in primary care. So we need to have, and we needed to address this issue, as well as the clinical training, as well as our effort to increase the number of GPs. And so we wrote about the three key areas to targeted efforts. And then so one is cultivating a stronger research culture among family physicians. This is the same for the mental health in primary care. So we have to encourage the Japanese family doctors to think about the mental health care in the primary care, so which is important. And also the fostering international collaboration through WONCA to help us build the capacity. So I think so. This is exactly the big mission for this MDD Minds project. So thank WONCA, and also addressing infrastructure changes, such as strengthening Japanese primary practice-based research networks. The same. This is the same. We need to need to construct the more strong networks among Japanese primary care practices, and not only the Japanese primary care, but also the global network is important. So lastly, the acknowledgement, the huge thanks to all. Thank you very much.
Thank you, Dr. Kasai. We have two more speakers, and I hope you are writing down some questions, because we have some time after our speakers are done, and all four of them will come up here and be a panel to provide feedback, to answer your questions, to think about next steps and where we want to go going forward. So Dr. Perez is next. Ana Perez is from Mexico, and Dr. Perez was a little bit of a latecomer, because she jumped into the Mexican side of the project after one of our leaders was not able, because of timing and family and all of those things that hit family medicine. And Dr. Perez jumped in and became a rock star for us. So she's here to share what they've done in Mexico.
Thank you, Shelley. Well, okay. Thank you. Well, let me introduce myself. I'm Dr. Ana Perez. I'm a young family physician from Mexico. I have a high specialty in medical family therapy too, and I'm so grateful to be here. Thank you for the opportunity to Chris, Dr. Christus too. Yeah, I'm going to begin. Well, there is some facts about mental health in Mexico that are so important to understand. In Mexico, there is a huge population and there is few psychiatrists. That's the reason, because we need more primary care physicians to get enough mental health attention and to diagnose depression, anxiety, and many other mental health issues. We have a few family physicians too, and that's a very challenge. In addition, we have other challenge because we have more or less 68 recognized indigenous languages belonging to 11 linguistic families with more than 360 linguistic variants. And there is a lot. Yesterday, I was talking with Shelley about that 6 months ago, I was learning to speak Zapoteco. And I was so impressed because they have another challenge and they experience the mental health in a different way in the same country. Yeah. For the promotion to the MDD Minds project, we have the help from the Federación Mexicana de Especialistas y Residentes en Medicina Familiar. Is a federal Mexican group of family physicians to integrate residents too. Well, about the program, MDD Minds 101 learners in Mexico, we had 18 doctors complete the online course until now. 7 doctors initially complete the first phase. Only 2 doctors continue in the next activities. And in general, among the practices they will be willing to implement were non-pharmacological techniques. And it was new for most of them. During the train the trainer, as I said, only 2 doctors completed train the trainer, and it was conducted in Spanish via Zoom. A total of 8 sessions were carried out in the train the trainer phase between September to October from 2024. I think that the most important results after the trainer is that both of doctors want to continue teaching colleagues about screening, treating, and managing depression. And I think that that is the most important result. Another important answers from the trainers is that they get enough tools to treat depression with pharmacological interactions is another topic that they would like to have the opportunity to take a course. They want to continue to update another courses. They mention a lot of times during the sessions, because our sessions was to 9 to 10 p.m. 2 days a week. And always we finish talking about self-care, the feeling that they feel burnout. Many times they express that feel sad for many situations around their works and the experiences with their patients too. The multidisciplinary teamwork point of view, it's or was so important for them. However, despite some difficulties that all that are here has, well, during the trainer phase, Dr. Dulce Adelaida Rivera Avila conducted 2 sessions in a public health institution. The first in November 14, 2024, with 59 attendance, and the second one with 40 attendance. And that's amazing. It includes not only family physicians, social workers too, nutritionists, psychologists, and pre-grade students too. The second doctor, Dr. Marian Flores Morales, had 2 sessions too, to 29 health workers in their sessions, but in another has more than 29 participants, and they were so motivated. They tell her that they need more sessions, more time to learn how to treat patients, how to detect depression. She feels so good to listen that. I would like to present their experience. I would like that you can listen.
Hola, mi nombre es María Flores Morales, soy médica familiar en México. El participar en este proyecto fue algo muy gratificante por todo el aprendizaje que pude obtener, pero sobre todo el poderlo transmitir a más médicas y médicos familiares para que todo esto se pudiera reproducir en la consulta, el darle la importancia que tiene el tema y el visualizarlo fue algo que me dejó una experiencia muy grata, el ver la respuesta de quienes tuvieron la opción de participar y ver la respuesta que tuvieron y el que lo pudieran aplicar en su quehacer diario fue algo muy gratificante. Agradezco mucho el haber sido parte de este proyecto y espero seguir transmitiendo toda esa información que pude obtener y además de transmitirla, seguir capacitando y seguir ayudando a visualizar este tema que es de gran importancia. Muchas gracias, saludos.
Here is the next.
Hola, soy Dulce Adelaida Rivera Ávila. Soy especialista en medicina familiar. Trabajo en México, en la Ciudad de México, en 2 instituciones de salud pública y además soy profesora de pregrado y de posgrado de medicina y de la especialidad de medicina familiar. Soy también investigadora con reconocimiento nacional y trabajo con investigaciones a nivel local y a nivel internacional con enfoque educativo y clínico. Participé en el programa de MDD Entrenamiento sobre Depresión y estuve en las sesiones revisando los materiales. Me gustó la oportunidad de compartir lo aprendido con los médicos y el personal en general de salud, médico y paramédico, en una de las clínicas donde trabajo. El que conceptualicemos que la depresión afecta cada vez a más personas y muchas veces no lo diagnosticamos. Fue muy interesante el que los participantes reconocieran la importancia de la detención de estas enfermedades. Al final de las sesiones, el personal participó y comentó sobre el efecto de estas intervenciones de educación continua y capacitación al personal en que ellos cada vez con mayor frecuencia ven que el médico de atención primaria indica el tratamiento tanto farmacológico como no farmacológico para las personas con depresión. Las personas con depresión tienen una enfermedad crónica que es susceptible de un tratamiento y que el equipo multidisciplinario de las clínicas lo reconozca, pues es un gran segura que estaremos participando en futuras intervenciones. Saludos desde México.
Well, we have lessons learned and challenged, but primary care professionals need to be trained in mental health, and that is a real situation, not only for for the diagnosis and treatment, but also for support patients and their families. It is important to validate what is already being done to recognize this. It is important to make healthcare workers' burnout visible, the difficulty of finding a suitable time for participants too. The challenge during the project, or the big challenge we had, was to have a very good schedule for the time for the sessions. Other challenge that participants detected was the difficult access to educating someone else, and administrative barriers to prescribe at primary care in some contexts. This is because we have 3 different public health institutions. And in my work, I can prescribe antidepressants and anxiolytics. The patients need to go first with the psychiatrist, and it could take 2, 3, 4 months to begin with the treatment, and that's terrible. Yeah. Well, I want to finish with this quote, this phrase, whatever good things we build end up building us. I think that this is interesting because in each encounter with these amazing 2 doctors, with you in all the meetings, it's, I'm sorry, it's, we became more complete. And the other day, walking the streets of this beautiful city, I came across a poster of an exhibition that reminded me of what we did and what we do today. It's called When We See Us. Maybe you saw it. And it made me think that the wonderful thing about these courses is the encounter with others, building our collective vision of health issues. And that is where our strength lies, in these collaborative projects that make a difference. Like, keep moving forward. Thank you for the attention.
Thank you, Anna. Thank you very much. Thank you. Yesterday, when the faculty met, some of the participants said, we only had small numbers. We don't think we were successful. Small numbers are huge, the changes that can be made in people's lives. And we're going to share a little bit of that next. Our final speaker today is Dr. Ariba, Joseph Ariba from Nigeria. And when 101 launched, Nigeria's numbers went through the roof because of Dr. Ariba. And as we all know, it takes someone we trust and someone we believe in to ask us. And he asked, and people participated. So it's his turn now to share his story.
Thank you very much. Thank you very much. Well, my name is Dr. Ariba Adekunle Joseph, and I think I should give a little background of myself so that we can understand, what's happening with mental health in Africa. I trained in a mission hospital. Then I went to work in a private hospital for about a year. Then I went to establish a Department of Family Medicine postgraduate training in a teaching hospital. And then I worked there for about 20 years. I retired, but I'm still engaged there officially. And then currently my trainees the faculty, they are the trainers in the department. And in fact, one of them is the deputy CMD of the art institution. And currently, I train online with about 5 postgraduate training institutions across Southwest Nigeria. So with that, I think okay. Oh, okay. Thank you. Nigeria is the most populous African country with over 200 million people representing 250 ethnic groups, and close to 40% of them are under the age of 15 years. Although the health entities show an increase in the prevalence of non-communicable diseases, including mental health problems, depression is the leading psychiatric problem affecting 12.3% of primary care patients in 2019. Of course, there are other problems like anxiety, substance abuse, and some psychotic problems. Importantly, the treatment gap in Nigeria for mental health is between 80 and 90 years, and 90%. There is shortage of mental health professionals, which is a major contributor to this gap. For instance, the mental health professional population is 0.16 per 100,000. That's quite low. Although several efforts have been made to narrow this treatment gap, there has been very little or no success. I think that limited or to non-inclusion of family physicians in the implementation process is a significant reason why this is delayed. Therefore, as family physicians, we look forward to ways to fill this gap. So when the opportunity of the MDD Minds training program came, we enthusiastically embraced it. And within the first few days of the registration portal opening, several of our members had registered. Now, when I was informed that this program was going to come on, it's like something I've been waiting for somehow. So what I did first was to create a primary mental care group for Africa. And then I created the Nigerian subgroup and used the various media to make it popular. And of course, we have very many medical groups in Nigeria, the Nigeria Medical Association, the Society of Family Physicians, and both national and within the state where I stay, and I belong to all of them. And actually, I've served in executive power in position in many of them before this time. So I just used that to leverage, and I said, WONCA is about to do something great. You wouldn't want to miss this. So if I were you, I will make sure I'm part of this training when it comes on. So everybody was looking forward to it. Then COVID came, if you remember, and there was a lull. And then, luckily, it came back again. And I said, WONCA is not sleeping. It's been working on this. Now they are coming big. And then we had that thing. And then just before we came to Australia, and that's how that people now started to register. So what we have emphasized the objectives of the training to ourselves, which is to improve recognition and diagnosis of MDD in primary care, equip family doctors with effective management strategies, and enhance patient outcomes through timely interventions. We keep emphasizing this so that people know that they're in for something that is practical, something that it's not just, oh, I'm participating in a program, but that after the program, I'm going to be proficient to practice it. So the enrollment, initially about 100 applicants expressed interest, 25 completed the course, MDDS 101, 23 registered for phase 3, 18 participated at least once in the Zoom meetings, 13 completed the phase 3. 3 centers were part of the performance in the performance program. And these 2 centers were actually we gave opportunity to 6 centers to be part of it. And there were criteria. One, you must be able to tell me in the past 1 year, what is your statistics? And there's the time frame. I don't have all the time to wait for you. So there's a time frame when you must tell me this, and I must look at it and say, okay, you have been, you've been doing some things, you've been seeing this kind of cases. And then I must ensure that there won't be too much problem in logistics, because there are different hospitals. And for some of them, you have to go to the commissioner, to the minister, before you can get approval to participate in this and that. So you wouldn't be part of that. That would be difficult. And then to some, if we have to ask you to give us that information, you should be able to do it quickly. Not that I will wait for a month, because you have to get approval to release that number and so on. So at the end of the day, 2 of those clinics were able to join. And one is a private hospital, a highly respected, well-known private hospital in Southwest Nigeria, Lagos. And then the other, of course, is a teaching hospital, but owned by a mission hospital. So, by a mission institution. So they're quite, you can easily interact with them. Within 24 hours, you get information from them. So that's how those ones came on board. The trainings, we had 4 trainings sessions in 2004. And most of them, of the scholars, were young consultant family physicians who were actively engaged in daily clinical care. Of course, I knew most of them. I had been the faculty, in the college, so many of them, I probably took them in exams and things like that. So when they heard that I was the one, they were enthusiastic. So I knew that I could follow them up. All the sessions were held in the evenings, according to the preferences of the majority. We started lessons on time and allowed scholars to make contributions. But I must say that here, it was a little bit tough, because these were people that were fully engaged in training, in providing care during the daytime. And some of them still had their practices, their private practices that they come to do. So we had to be tolerant. Some people will have to come 15 minutes late. And in fact, one day, one of them told me, "Sir, I have to be truthful. After the first half, I slept off." I said, okay, sorry. So, we had to accommodate people in this manner sometimes. Scholars were also encouraged to use local and native examples. At the beginning of each session, participants were asked at random to recall salient points of previous class, so that we are sure that they are ready for the next class. So what were the key learnings? Well, one thing perhaps we have been taking for granted is the amount of preparation that had gone into this program before coming on board. And I really want to appreciate the steering committee, because the way, when they started, the way things started moving, you knew that a lot of work had gone into this, that this is serious business. And it is in that same manner that I had to transmit that to people, that look, this is serious business. People have put a lot of time, a lot of energy into this. And you could see it, from the way I was troubling this gentleman. Within a few seconds, I asked, please, so, as if he doesn't sleep. And everybody, I ask questions from Mary. The answer is back quickly. So I know the people at the end, they are serious. So I will also be better get serious. So it was important that we need to understanding the major depressive disorders. The criteria and assessment tools also needed to be understood. Management strategies in primary care were well laid out, and case studies and practical applications. So these were things that we also emphasized during our training. Now, in the performance in practice program, this was really an amazing program. The sequence of activities that the scholars had to do was ordinary, but the impact was near extraordinary. And you will see this from the expressions, as we go on. It opened our eyes to how closely these morbidities coexist and how they can both be effectively addressed at the primary care level. Importantly, it showed how a health system can be easily organized. For instance, when we asked, how would you rate the train-the-trainer sessions? You could see from here that quite a large number of people said the sessions gave me time to interact with colleagues and faculties. Now, for a lot of family physicians, particularly those who are in independent and solo practices, most of them just get busy with their practices. And it is a real opportunity for them to actually, once again, have this interaction with their colleagues. So it was quite exciting for them to do that. And so this is what they were expressing there. And of course, how would you rate your overall experience with these trainers? And of course, quite a sizable said it was excellent, and quite a number two said it was good. So let's look at the feedbacks and reflections from the participants. Many scholars had much to say about their experiences of the program. One said, I enjoyed each meeting session as it added significantly to my knowledge of depression and care. I was also able to interact with colleagues and learn from their wealth of experiences. A major influence of this training had on me and on my practice is the better understanding of the non-pharmacological approach to care. This was from a male scholar from a faith-based teaching hospital. Another one said, the MDD Train the Train course has opened my eyes to my role as a family physician in the reduction of the burden of depression in the world. A major influence this training had on me and my practice is the better understanding of the non-pharmacological approach to care. It has resulted in recorded successes in my patients. I pick up depression and on them and on whom I have applied this. It also reduced the rate at which I resulted to use of drugs in these patients. And I've had good outcomes with management with only the non-pharmacological treatment without necessarily needing to use antidepressants. Finally, somebody said, I got to know about the WHO 5 key approach to managing depression through MDD Minds. Also, I gained more confidence in applying cognitive behavioral therapy. Before, I would rather commence every patient with depression on antidepressants than follow any non-pharmacological path. This is from a faith scholar from a federal institution. Most people medicalize mental health problems. The moment you get there without this kind of training, oh, this person has a mental health problem. So it's an antidepressant, so it's but now people are realizing that they can actually do non-pharmacological therapy. And from the performance in practice participants, the reflections, somebody says, participating with WONCA Quality Improvement Program on depression screening for patients with chronic illnesses, especially diabetes, was transformative. Learning in training, I received the MDD. I trained colleagues to identify and manage depression, enhancing patient care. Introducing routine screening meant initial resistance, but we overcame this through daily reminders and collaborative efforts. The initiative revealed undiagnosed cases of depression, underscoring the need for systematic screening. It also fostered teamwork with the medical records team to analyze data and refine practices. This experience emphasized the holistic approach to family medicine and improve outcomes for patients with chronic illnesses. Screening for depression is now integral to in our care and should be monitored by the Quality Assurance Unit. This is from a senior resident. So this is a testimony that this program has actually transformed practice in that place. They had resistance because in this practice, people were not used to all this finding out that somebody who has diabetes may have something else, especially something that is mental health problem. They understand if you are saying, okay, what are the main complications of diabetes? You have to screen for that. But we're talking about mental problem, that was common. So there was an initial resistance that this is not the main thing. But when they started seeing the results, they found that this is something that they must get onto. Then finally, he said, the 12-week journey has been an odyssey of discovery, growth, and empowerment. Our team has gained invaluable knowledge, skills, and confidence to tackle complex clinical presentations of depression among patients with diabetes mellitus. The program has fostered a culture of early detection, revealing the tangible difference it makes in patients' lives. In the course of the program implementation, the percentage of adult patients with diagnosis of diabetes who are screened for depression increased from initial 0 to 10% in the mid-course and has been sustained since then. This is one of the male consultants. And in fact, this consultant was so, impressed and, involved that he actually started to write a proposal to do this, to screen for this across the southwest Nigeria. That proposal we are sure will soon be approved, and we have actually started collecting pilot data to see how it's going to work. So, challenges and local adaptation. Well, of course, we have online training challenges. We start, and even me that is starting, the light goes away, and they have to apologize, get another source of light, energy, like generator, and then we start all over again. And, so we had unstable networks, expensive network data for a lot of people, and finding suitable time for everyone for the online meetings was a little bit difficult, but then we had to have an agreement. We voted and said, okay, this is the time we'll do the next one. Then there was an initial delay in using the Trello because we're not used to it, but with time, people got used to it. Participants finding trainees and conducting the trainings initially was a little bit difficult because this was something quite novel, but then when they got into it, they found that it was very interesting and they didn't want to stop. Impacts and outcomes. Immediate impact. The knowledge and skills of participants regarding MDD recognition and treatment have greatly improved. And that includes myself. Increase in commitment to non-pharmacological therapy and screening tools. These scholars have actually trained others. And one of these ones went ahead and trained others who later helped in the PIP program. That was very exciting for me. She wasn't in the mainstream among those who did the 101, but she was now trained, and with that training, she was able to train others, and they participated in the program. Impacts long-term. More research directed at MDD among patients with chronic diseases. We are committed to continue this practice beyond the program's completion, driven by our passion for exceptional patient care and improved health outcomes. We are currently contemplating integrating depression screening into the routine care of our patients with non-communicable diseases in general. Beyond the screening, the MDD Minds training and the subsequent TOT course has really helped in capacity building among our local teams. This was said by one of the consultants participating in the team. And like I said, an offshoot of this program, there's a multi-center study that is currently conducting a pilot study on depression and distress in diabetics across the country. In conclusion, the MDD Minds program has arrived at the time it is most needed, when the need to close the mental health treatment gap is most urgent, particularly in low and middle income countries like Nigeria. In Nigeria, the program has proven to be impactful as scholars enthusiastically engaged in the training showed evidence that the supporting tools made the program easier to understand and implement. Importantly, scholars were able to accurately duplicate what they learned by training others who also went ahead to train others. Further, all the first-generation trainees have committed themselves to sustaining the program through continued practice and research. Thank you. Some references. Thank you very much.
Thank you, Dr. Ariba. If I can get our 4 faculty members to come up, grab a chair. This is a little informal, but it will work for us. As I listened to conversations yesterday and as I listened to these 4 today, there are a couple of concepts that came to mind to me. One is culture and the differences in culture and how we address mental health in each of our cultures, and the importance of us sharing what we have learned and how we address mental health issues to help each other better understand. The other was community. The fact that you all were able to build communities locally. So it was Yasmin's group meeting at a local restaurant to talk about their issues. It was a very large hospital group. It was an urban clinic. It was one of Andre's clinics who were meeting outside in kind of a palapa type of arrangement. So it was building our local communities, but it is also strengthening the global community of family physicians who have at their very hearts the care of patients. And then the third one for me is relationships. I think the heart of family medicine is the relationship. It's the one-on-one with the patient. It's the one-on-one with the young family physician we are teaching. It is the expertise in our senior faculty. And it is WONCA bringing all of us together around a table to build those relationships. I think the program helped us reduce stigma. We're talking about mental health, and 10 years ago, no one talked about mental health, particularly healthcare professionals. They never talked about their own mental health because there was such a stigma in a doctor having a mental health issue. And we've also increased hope. We've increased hope that we can manage this, that we can screen it, that we can help our patients. And the patient stories that some of you have shared are just heartrending. So I would like to open it up to the group here. Do you have questions? Do you have feedback? What would you like to learn more of from 4 of our master faculty members? And raise your hand or shout out, and I will run with a microphone. Who has a question? Because I will ask them if you all don't. Steve.
Thank you, Shelley. One of the reflections hearing all of you is about actual physicians suffering from depression and realizing that through the program that they have a problem themselves. And it always makes me think of the airline analogy, pull your own oxygen first. You know, how do we look after patients if actually we're suffering ourselves? I wondered how you actually manage that in the moment. You know, if someone during a teaching session actually raised, oh gosh, I think I'm suffering from depression myself. I wonder how you manage that. And then the second reflection is, I wonder if this is a global phenomena that actually burnout and depression amongst doctors is rising. because it feels that way. Wherever I go, I hear this, and I wonder whether if there's any evidence for that. Thank you.
Thank you. Panelists, and you have a response to how you manage when one of your colleagues or your students comes with depression? Andre?
I can start. Yeah, that's a very interesting point. Yeah. As doctors, I think we also have our own stigmas. And as Shelley said, the program reduces stigmas. Yeah. So that's an opportunity for them, yeah, to search for help, to search for a psychotherapist, to search for a psychiatry, to search for more healthy activities, for changing their lifestyle. Yeah. And that's the best part to hear. Yeah, most of them come to me already doing this sort of thing. Yeah, they said, Andre, I recognized myself with depression, and I already searched a psychotherapist, and it's helping me a lot. Yeah, or I started my gratitude diary, and it's helping me a lot with deal with my difficulties. Yeah, or I started jogging or making something to improve my quality of life. And I think for me, that's one of the best parts of the course too. Yeah, because to take care of our patients, to take care of our world, we have to take care of ourselves. And sometimes when we are doctors, we forget a little about it. Yeah, we are very interested in taking care of the others, and we forget about taking care of ourselves. Yeah, so this kind of program is very important to aware us about it. Yeah.
Thank you. Others on the panel, Ryuki.
Yes. Yesterday, the Mary kindly shared that that the data that the Japanese participants showed the fewer percentage of doctors who would like to show their anguish towards others, and they don't want help. So during the course, I didn't have any chance to realize that they got someone would like to confess that they got depressed. They had an experience of depression, but I understand culturally that they wouldn't tell their anguish to others. So I sometimes said to them that it is okay to talk about yourself. And also I showed them some example of mine, especially my experience after I had the heart attack. And I realized the importance of the cardiovascular rehabilitation, including psychotic support. And this is okay to have this, and this is okay to make everybody around you know about the fact. So this is my approach. Thank you.
One of the things I noted when we were putting together the 101 curriculum in the 7th module on self-care, our master faculty were all very generous and agreed to be vulnerable and share with everyone who was listening to that session what they do for their own self-care. And I think that was very important. In the United States, I don't know the exact statistic, but we lose the equivalent of one medical school class every year to suicide and physicians. And we can't do that. We have to support our physicians. So, Abdullah, you have a question for our group. Ask away.
Okay, thank you, thank you. We have a challenge in Middle East countries. I want from your experience how you cope from that. Really, we start to integrate mental health in primary health care since 1995. But unfortunately, all national work and train the people, it's failed. Then unless we found the way why it's failed. Alhamdulillah, now we succeed in that. But what was the problem? The problem, if the patient coming with drinking a lot, go to bath a lot, oh, so the doctor will suspect this is a diabetic and go to manage that. Or patient coming with organic disease who coming to with the symptom clear, as we learned in medical college, the chief of complaint, history of chief complaint, tick, 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 we reach the diagnosis, we need the management. But this is not working with the depression or mental health at all. In our culture, nobody will come and say, I am sad, I feel upset. Okay, so our problem is not how to diagnose, not how to manage, how to pick up patient need service. So I want to learn from you how to cope this, how to pick the case, because patient he not know that he's suffering from depression, hidden, and the doctor also he think he deal with the good thing. And I will tell you very short after hearing from you how we cope with that. Maybe also can be share the experiences.
Great, thank you. Dr. Ariba, Joseph.
Yes, thank you very much. That's very common too in Africa. Our people, I can't remember hearing anybody saying, I'm just depressed today, I'm sad. That's why I came to see you. It's very uncommon. And that's why cultural competence is something that we emphasize. And it's also inside this module that we should ensure that we are attuned with the culture, the presentation. In my country, for most of the ethnic groups, people tend to somatize their mental health problems. And in fact, when somebody feels he's sad, the way he will be putting it, depending on how religious he is the reverse. He say, thank God I was not sad. Oh, that tells me that this person was sad, you know. And then they describe usually a plethora of symptoms that has no direct physiological or anatomical linkage. For instance, somebody comes and tells you that I feel a movement right on my umbilicus. And then it moves and moves and moves. Then it gets to my heart. And then it does boom. And then I cannot get myself. You see, such phrases, I can't get myself, tells me that this person is trying to describe something that is not happy with. So that makes me think this person might be having a psychological problem. So that's one, clue. So they give you somatization of the problems rather than, because some of them don't really have the words to describe those symptoms. Secondly, culturally, a lot of people cannot say something that is negative about themselves. Culturally, even when that is what they mean. So you need to be in that culture to understand it, that this is what this person is trying to express. And with that gives you a clue. And you can then now start, okay, could this be the depression? Could be the anxiety, whatever. And then you now start the regular questioning and assessment. And of course, your program, your work is also very helpful to some of us who have gone through it too. It helps. Thank you.
Other panelists on how you recognize.
Yeah, but I want to speak about another kind of problems that are linked with this kind of situations, because there is, or at least in my country, there is institutional problems like the time that we have with the patients to identify many psychosomatic diagnoses. we only have 15 minutes. Sometimes the patients will come back in 2 months because there is a lot of patients, and it's a terrible situation to get a space to the consultation time, and that's difficult, the diagnosis and the non-pharmacological treatment too. And that linked to the burnout situations too. Yes.
I have a point. There's something very interesting in being a family doctor that becomes a psychiatrist, because I have very two different visions. Yeah, when I use it to be a family doctor, and that's why one of the reasons that I became a psychiatrist is that I felt sometimes very frustrated because the patient came to me, I have a headache and he never got better. I have a stomach ache and I never got better. I have a pain or something like this. Yeah. And I started to notice that they have emotional suffering. Yeah. And when we know them better, we see that they don't have pleasure in their activities, they have problems with their families. So if I gave them an analgesic, he won't get better. Yeah. So that's why I started to learn more and more about mental health. Yeah. And then it started to help. And that's something that we use it in the MDD Minds program that I think that helps a lot. There are two simple cash questions of PHQ2. Yeah, that might be always in our practice. Yeah, are you having pleasure in your activities? What are you doing to have pleasure? Yeah, and something that we discuss a lot in Brazil that I think we should always ask is, do you drink alcohol? How is your use of alcohol today? Yeah, because we have a lot of problem with alcohol abuse too there. Yeah, and it's very linked to depression. I think we can say today that depression is a lifestyle disease, such as obesity and diabetes. Yeah, so it's a point to suspect always too.
Wonderful. Thank you. Thank you. Ryuki, anything from you?
Yes. It's been already 14 years after we were hit by the big earthquake and the tsunami and the nuclear power plant disaster in Fukushima. And so no matter what kind of problems, especially so when the patient talked about a lot of physical symptoms, then I myself always asked the one question, and then also I encouraged my trainees to ask the patient that, what were you doing on that day? And then the story is started by the patient. The first, they don't want to talk about their emotional things, but the gradually so they can develop their story until the healthcare problems. So this was what I did.
It's a very different engagement with patients because it's not something you can answer in a 15-minute or a 12-minute appointment. It's something that takes time, but it takes that relationship as well. And I think that's what's so important is you all have those relationships with your patients. Other questions, and then I'm going to come back to you. Cindy.
Thank you very much for the sharing. I was really very impressed and very heartwarming to hear all these capacity building. So my question is that, like, you sparkled a lot of fires among the family doctors through the trainer program and also for the replication of the training. So what's the next step? How are you going to actually help to keep this fire going and then spreading this fire? So, and what kind of support that the WONCA and also this program can offer to help you to sustain that momentum in your own country?
She's putting you on the spot.
Yes. Well, thank you. In my own end, it's like this is something I had already been thinking about because it was a problem even before this program started. That was why I said this program arrived right on time. So we have put a group in place, and we are encouraging many people to join that group. It is from that group that this cohort of scholars that have now become trainers came out, and we've been able to increase their interest to the extent that they are now ready to carry out research in this. And with people engaging in research in this, it means they will get more and more engaged. And of course, we also hope that periodically, because that group is intact, periodically we will engage ourselves again, remind ourselves, and encourage ourselves, and ensure that they too are training others. So that's in place. And we are also looking for what is coming from WONCA. We know that WONCA will not stop here. So that will continue to be something to encourage us to say, I told you, WONCA wasn't joking. Now, this has come out again. So we continually engage ourselves. That's in place for now in Nigeria. And I'm sure, I hope it will spread across the continent.
Others on our panel.
Yeah, I really want the younger doctors in Japan to engage or participate in this international network activities. So for those, I don't know how many Japanese are participating through the YouTube stream to this session, but so yeah, please think about the international network like this, and please, and then we would welcome them as the team. Yeah, thank you.
Andre?
I have the impression that we haven't stopped yet. I think that many students are still making their replications there in Brazil. Some of them are really enthusiastic with the program. And as now we have the website launched, yeah, with the materials of MDD 101, I think that many doctors will search for it too. And maybe an idea would be to make train the trainers and performance in practice just one course together, yeah, and make spread it around Brazil, for example, but per regions. Yeah, I think it would work better as we have a very large country, and we can have the support of the governmental institutions. We have many health educational institutions, such the public health schools, that can support with the replication specifically of train the trainers and performance in practice, because we have very, very nice materials, yeah, and we can lose it. Yeah, we have to spread it as much as we can. That's my opinion, and I think that you think something like this too.
Anna?
Well, we need to tell this before, but in Mexico, we have an offer to include this program, the MDD Minds project, to the curriculum of one of the biggest public health system. Yeah. To be part of the residence curriculum of family medicine. Yes.
That's wonderful. We have some questions, and Christos, you are going to get the last question because you are the heart of this for us. But we have questions here from Dr. Dowrick, who's been paying attention online and has a direct connection.
So Chris had sent me two different questions, and One is a broader question. I'll do that one second. But he was struck by as he says, the enormous variety of languages. And I would even say then subcultures within, or indigenous cultures within your countries. And how can those issues best be addressed? So the variation of languages within your own countries. That's question one. We'll go with that one.
Okay, maybe I should start that, because surely in my country there are truly variety of languages. We have over 250 ethnic groups, but luckily, although there are the dialects differ, there are central languages. Let me put it that way. For instance, in the southwestern part of the country, we have many dialects, but everybody understands what is called the Yoruba. Every other place, every other language in that dialect is a variation of that Yoruba. So Yoruba is the language that is spoken in the southwest. So once you understand Yoruba and the culture, the central cultures of the Yorubas, then you are likely to be able to do well when you are engaging the patient. That's why in Africa, we keep emphasizing being culturally competent, because just one word misused can switch, the patient can just switch off and say, no, this person cannot help me. So, and in the eastern part of the country, there are also, again, many languages, but Igbo is a very central language to them. And of course, the majority of the north, they speak Hausa. I speak a little Hausa because I did my youth service in the north. So I could also pick some psychosocial problem in a Hausa man, but not as easily as when the person is a Yoruba person. So, and that's why one of the things that we will still do is to include people from other parts of my country as trainees and to be trained. So that's why this thing has to continue. We can't just stop, because if you look at the catchment of these people who participated, initially it was spread around the country, but the number of people that actually completed were more towards the southwest and the east. So we still have a lot of work to do to ensure that we cover the whole country, so that we'll be able to attend to people of other languages and cultures.
Yes, but I think that we need first to have the interest to learn another language, because it's another world. The person that have been teaching me Zapoteco told me that in her region there is only one doctor to speak Zapoteco, and it's so famous because of that. There is many challenge around that. Yeah, but it's necessary. Yes.
I think that in Brazil, the main point is not the language, but the cultural approach to the indigenous communities. We have now some institutions discussing a big problem that we have with the increasing numbers of suicide among indigenous. Yeah, but unfortunately, we don't have an answer yet. Yeah, we're discussing that since pandemics. Yeah, and it's really worrying us. But unfortunately, we have not the right way to approach, because culturally depression is very different from them.
Yes, in Japan we have a lot of dialects, but dialects itself is not that big issues. But to pay attention, only attention to the words and the names of emotions, such emotions and so on, is risky. And I'd like my trainees to pay more attention to the more phrases or the stories they share with the patient. That is a safer approach, I think.
As much a comment, treatment gap is very impacted by having so few family physicians per head of population. And I'll extend that question, which is how then do we integrate sort of the need for more family docs in your communities, and acknowledging that mental health is part of that responsibility as a family physician?
Great. So how do we increase the number of family physicians, and how do we ensure that as they are trained, mental health is part and parcel of their practices?
Okay. Well, it's in terms of the number of family physicians, our problem is not really getting the people to become family physicians. We, as things are, in the two colleges in my country, that is the West African College and the National College, we luckily are still having a lot of people preferring to read, to specialize in family medicine. But our major problem is retaining them within the country when they finish. Previously, you can be sure that when somebody finishes his specialization as a family physician, he will be in the country for the next 5 to 10 years. During residency, he wants to sit down first and, gain back all that he has lost as a resident, and then before he starts thinking, oh, is there an opportunity to go out? He will have spent like 10 years, and then another one will have been trained. But what we are facing now is that for a lot of them, even after they just passed the part one, they are already thinking of doing an external exam because they want to move to North America or somewhere in Europe. So that's a major problem. However, the few that are staying behind, we are encouraging them to prefer mental health as an area of specialization. For instance, I, as a general practitioner, have 3 main areas of special interest. Mental health is one of them, then reduction of maternal death, and assessment of quality of care, of healthcare. And now, mental health is my current engagement. And I've let people know that if you are choosing a topic for your dissertation or whatever, you will be preferred. You will get more attention more quickly if it's mental health related. Maybe that's unfair, but I have a right or what I'm interested in. So I'm doing that, and I'm already seeing that a number of residents are already choosing topics that are mental health related, and I think that's a way to start. Thank you.
That's a good way to start. Others, how are we going to grow our workforce and make sure that they're practicing mental health care?
Yeah, it's quite difficult, as you see in the last slide, and we needed to address the both micro and micro levels of society and healthcare systems. So maybe if it's possible, the WONCA would send a kind of an ambassador to Japan and then hold a press conference and to let the Japanese society, Japanese media know that the primary, that the mental health care can be safely addressed in primary care level.
So it's raising the awareness of family medicine and primary care, having the capability to integrate mental health into their practices. Andre, how about you?
In Brazil, we have growing, increasing number of doctors graduating, and this is naturally leading them to the family medicine medical residence as they can get a place in other specialties. Yeah, we also have programs such as More Doctors to Brazil for almost 10 years that gives financial incentives for them to work in primary care. And as they go to primary care, they fall in love and they want to study family medicine. And that's something interesting that began in the last years, that now we have an extra year on mental health, yeah, for the medical residents of family medicine. You can make your residence on family medicine and stay for one more year for mental health, focus in depression, anxiety, and psychosocial interventions. Yeah, that's a very nice point too. Yeah.
Wonderful. Just a second. Anna?
Okay, I think that we need to create great models to be visible for the residents and for the students in pre-grade to have more family physicians. They could say something like, oh, I want to be like him or like her. And the other one is related with my previous answer, because it is so difficult to have doctors to want to move to rural sites. But maybe it could be resolved with the addition of an extra pay or the recognition, society recognition. Yeah, maybe.
Yeah, moving family physicians into rural communities is difficult everywhere. It's not
Yes, I
just
know.
for you all, it's for the world. We have time for one more question. And, oh, Yasmin, please.
I was thinking that mental health is multifactorial, so socioeconomic and a lot of things around us. And I think it's important also to work in teams. Primary care has teams like your nurse, social worker, psychologist, so it's good also to work in communication with them, because sometimes we as family doctors can't do everything. So I need a psychologist, I need a social worker, please take a look of this patient. So I think that don't feel alone, that try to work more in teams. I think that's important. And also we need the help of the government, the public health, so like to working with more things. Thanks.
Thank you, thank you. And Dr. Leonis has our final question, and then we will break for lunch. If you have questions, keep them in your cards, because our afternoon session, we have more time for questions. And our live streaming audience will actually have its own session and an opportunity to make their comments and ask questions. So, Christos, final question for our
actually,
panelists.
it's not question. It's a suggestion
Okay.
for all of us, to panelists, but all of us, and only a very short question based on research. I think that's I've been inspired from all of this very insightful presentation. I'm thinking that MDD, to go further, needs a guidebook. And instead of hide the book, and that's I'm suggesting it to a WONCA executive, just thinking potentially a new book with the CRC groups, just entitling integrating mental health into primary care through the experience and the implementation of MDD training program. Potentially, we could start with the needs assessment, which actually the phase one, and giving an illustrative presentation of the structure of the content of the program, giving a more focused later on training the trainers and the implementation. And finalizing with the presentation of a best practices, because all 9 settings are best practices. And just giving a real example and how to design and implement a training program. And that's under the colleagues of WONCA now. Potentially we're just having a digital version, not only just a book, included so many patient stories or testimonials and many other. I think that's potentially now orally raising it. And finally, since already I affected by one of two slides from your paper, and also Joseph a little bit focus on research. Both, I'm not quite clear for me if family medicine at the moment needs, or family physicians need a more thorough exposure to research methodology. I'm thinking now, I have in front of me fantastic statements and books of American philosopher Thomas Kuhn. And I'm thinking that now we have the need to change the paradigm. Since all research methodology is closely related with the outcomes of research. And I'm thinking that outcomes, clinical outcomes, have been decided on the hospital setting. And based on this experience, we're thinking now in giving them more focus in other subject like wellness, suffering, eudaimonia, which means spirit. I think that all of these subject potentially with physicians' happiness and patient happiness. I think that's all of those subjects and fields potentially just needed to attract our attention in changing the paradigm, changing the effectiveness of the clinical and in general work of general practice. I'm thinking that based on your excellent publication, I think that now we already discussed with my colleagues in WONCA here.
Thank you. I think Christos has left us with a challenge to begin a new text on how to integrate mental health into family medicine. And there are so many ways to do it. And every way around this room is different. And every way around this room is a best practice. So that is a challenge for us. And there is also a challenge for us in research and showing that family physicians make a difference in the mental health care of themselves and of their patients and their practice teams. With that, I'm going to thank my panelists and our master faculty members. Thank our live streaming participants. We are going to break for some lunch. Roberto, you have practicalities for us, right? Instructions. Will you do now?
Right. So for our lunch break at the back of the room, you can serve yourself. We have a selection of wraps and sandwiches. We have a vegetarian option also for those. And at the same time, we're going to have our interaction with our participants who are joining us on the live stream to try to also grasp from them their impressions and enrich further this session. Thank you.
Thank you, Roberto. Sorry to put you on the spot, but you always know the details. So be back and be ready to work by 1:30. Okay? Lunch is in the back, restrooms in the hallway, outside for fresh air.
you. you.
you.
you.
Welcome back, everybody, from our short little break. We're ready to start the afternoon session here. We're going to start off with a few presentations. And for those of you who are on the YouTube Live link, then later we will, or shortly thereafter, we will engage you in conversation while there are conversations going on here, and then have you all be part of the debriefing. You can hear everyone's voice from around the world via the magic of the internet, as well as here, those of you here present in the room. But right now, we'd like to ask Dr. Leonis to come up and share with us the work of the Working Party.
Thank you very much. Very much appreciate for giving me, on behalf of the steering committee, in giving us some impressions about the activities that we carry out, and potentially that's seen how all of these activities are interconnected with the MDD project. I think that's. Thank you very much, Dermot. Always, all are very grateful for the time that you providing to us. Coming from that time, it's okay. Okay, thank you. I think that it's just a little bit illustrative pictures on our current president, and already Dr. Lilidakis presented a lot about activities of. We're having a very important composition, and many thanks to our colleague Sanka, with us also supporting with the WONCA Young group, also offering many opportunities in having wonderful colleagues, representative of young generation. We hope to continue that. As you can see, and you can read all the names of important colleagues we assist in a great extent our working party. We're having, of course, family physicians, general practitioners. We're having psychiatrists and general practitioners. That's a double mission. Psychologists and also public health. I think that's a wonderful integration of different disciplines. Past president is Professor Chris Dorick, and Vice President Professor Al-Khatami. And I think that all of this, we're having, of course, a representative from all the regions. And at the moment we start thinking, continue such process, giving more opportunities to young people and offering the insightful. I think that is one of the issues already have discussed, and I'm putting it there because even in the morning we discussed about integration, and Stephen and Harry, so we needed a little bit in discussing more, actually in collaboration with the WHO. This is the last only book or effort have been achieved through the kind mediation of Professor Ivi Bijaro, Gabi, at the time when Gabi was actually a chair of a WONCA Working Party, is giving an opportunity in thinking about this very important effort since 2008. And that's Professor Al-Khatami, that's what we're discussing about the integration. That I think that's still, we're trying a little bit in thinking and discussing and making more clear the connection with the WHO, and especially Astana Declaration. Already there are key messages that about the mission at the moment of WONCA Working Party, giving more importance to patients' vulnerability and the impact of poverty, and giving more focus on health inequalities. But also just talking about mental health promotion, because many times we're talking about mental illness, it's a very severe mental illness, but not to mental health promotion. And also just discussing about antistressors or 5-step reducing the stress, your approach, but also the health asset. I think that is, of course, we discussed all 2 days about our project. This is another project, and thanks again to Chris, but to many colleagues, and Cindy is here, and many thanks also to Cindy, and one of big mentors we have in this is Professor Larry Green, always Shankar is, of course, a strong partner in this. This is the publication from the first round. And now we have in this from my colleagues, Dr. Marilena Nasasaki, which are giving an excellent evaluation of the second round of the. I think that advocacy project is strongly related with MDD. This is one of the main. This is just a little bit of supporting the future leaders. And now, if you're thinking based on MDD, we have in around of 200 at the moment leaders, means well-trained people, which are potentially giving us opportunity to continue. This is another issue, and many thanks to Dr. Ligidakis and WONCA. Since already we have discussed this, it was another initiative of our working party, trying a little bit in supporting and giving more training in reducing the stress, enhancing compassion and compassion satisfaction, reducing the suffering of family physicians working in settings under stress. Started from Ukraine, where just we have in the conflict that enormous war, have a negative impact to family physicians, and continue with Brazil, we're having family disasters. That we prepare in this, we say in MHAT, and Marilena is a coordinator of this effort. It's a member of a working party. And I think that we have prepared some pioneer, if we can say, in material. And we started the discussion with the executive board, how all of this experience could be synthesized and given more. I think that's all of these theoretical frameworks that we're using in the MST project. And this is another project that's also interrelated. Our colleague and a member of a working party, Alfredo from Brazil, also is the coordinator together with the Chris Doric. I think that is a unique opportunity also in exploring such direction to see how to incorporate in the current version on FMD. And this is the recent publication in Open British General Practice, where just giving opportunities in disseminated further the structure format and the tools of the music project. But of course, we have another important activities initiated and coordinated by Professor Al-Khatami, and having this is Al-Khatami 5-step approach in reducing the stress, a very simplified procedure, and through this project we have a unique experience in closely collaborating with North African countries, including Tunisia, Morocco, and many. And of course, that is another opportunity, another dimension, another direction to incorporate in MDD project. Of course, we have a lot of opportunities in discussing and making conferences and offering networks expansion and also discussing several promoting several webinars. I think that is the two books with the CRC. The first book with editor Chris Doric, and then now the other under the support always, of course, with the WONCA. We're planning to present. Many of you have included in different chapters. This is challenging in primary mental health, and that was a previous idea. I had the pleasure and honor in raising, just having a similar not saying guidebook, but another book just focusing on MDD. Of course, this is another area we still still under exploration. We're having a close collaboration with several experts from National Health Services in the UK. Dr. Papadakis is working and serving in National Health Services, also is a member of our university. Already have discussed to what extent could addressing also people who are having chronic illnesses behind, and I'm talking about non-communicable, of course, disease, and also still smokers. This is based on a panel of experts, and now we're planning to prepare, and we're preparing a type of practice guidance. But I think in that chronic diseases and smoking together, and just it's just unique, if we say, in combination with mental illnesses, and you need it a little bit in addressing a little bit differently in comparison with other people. I think that's I try a little bit quite quickly to summarize our achievement, and also just giving now a sense, a feeling that potentially all of these individuals, if we can say, in project, potentially could offer, contribute to a new insights, and offering new insights and additional potentialities to MDD project. I think that's my thinking, that not spending 15 minutes that you provide me. Thank you.
We have a few minutes. Any questions for Dr. Leonis before we let him sit down? You'll have opportunities to ask him other questions later. But any questions about the work of the Working Party, or any Working Party members want to add any comments at this point?
Descriptive.
Well, thank you very much for the presentations. Actually, it's a general question. A number of scholars have been saying they want to join the group, and I usually tell them, first go to the website and then join with be a member of WONCA, and then with that it's easier for you to migrate. But I don't know exactly what we should do for people who say, oh, I want to be part of the mental health group. Exactly what should be our message to them? Thank you.
So the practical message is on our website, membership portal, application to become members. That's quite easy, straightforward. And then we receive their membership application, and through the membership portal, those who are delegated to approve the applications from your working party do so. It's quite straightforward.
Thank you very much. As you know very well, I'm not daring in making a suggestion in front of so many experts that only offering all of this as a paradigm in facilitating this fantastic Joseph proposal. And many thanks to Dr. Legidakis that's giving us. I think that we needed to having an offering such membership through to our working party, but also that's we needed to discuss potentially in the next this week. We're having a steering committee in giving also or preparing an individual group that's working together, that's giving a unique direction that will be a subgroup affiliated with us, having a coordinator inside and giving some or reporting to us. I think that's potentially is a unique opportunity, and many thanks.
Wonderful. Well, thank you all very much. Thank you, Dr.
Thank you very much.
Leonis.
Thank you.
At this point, we'd like to ask Dr. Cindy Lamb to make a few comments. Dr. Lamb has been one of the members of our master faculty who has not had a group that she's working with. And as a result, that's given her an amazing perspective to seeing the beginnings of this project, understanding it within the context of the working party, and now coming back to see the work that you all have done. So, Dr. Lamb.
Okay, thank you, Mary. Yeah, it's a bit sad that China could not actually take part in the first MDD 101 project because of the language issue, and then of course also the access to the internet issue. But anyway, Harris was telling me that that's the next step. Thank you very much. So it's really not a presentation, but I would just probably want to open this afternoon's session to hear more from everybody about where do we go from here. And so basically, I'm charged with this, the responsibility of moderating this. So we're going to actually discuss how we're going to strengthen mental health capacity in primary care. So we've actually heard the very, very successful results from the MDD Mind project, and also heard a lot of the sharing of the experience of how we actually take an idea and apply the things that we have learned through the training course into practice. And we've actually heard about some of the plans of how we're going to actually scale up this thing. So I hope that we can actually all consolidate that and actually have contribution from everybody, including people actually joining on the YouTube Live, to really look at more specific strategies. So on how we can actually do. So the emphasis is on the how. Okay? And the second is actually strategies that's actionable. So within the next months rather than years. And specifically want to actually focus more on actually how we actually build the capacity through training. We've actually heard a lot about, and the resource, instead of distribution, but the redistribution of resources. Like how can we actually get the healthcare services resources being channeled more into primary mental health care, and also the cross-sector collaboration we have also had some discussion about. And then the second thing is strengthening the policy framework. Policy is the driver for normalization of practice. Without the policy, we've heard actually, in some places where the drugs are not even available. Nothing is more frustrating than having somebody who's been trained, wanting to do something that is primary mental health care better to serve patients. But then you don't have the resources, you don't have access to the means, okay? Be it time, remuneration, and also sometimes drugs and other collaborative services. The last but not the least is actually what are the future steps and sustainability of the WONCA mental health initiative in the future, okay? And this may be in the coming years. So I want to actually just highlight another part of work that actually WONCA has done in collaboration with APAC. And can we change the next slide? So this actually was the result, this publication is the result of a meeting between APAC and WONCA. In the meeting in 2019, early 2020, basically we look at how we can actually take this very good idea of integrating mental health into primary care from an idea to action, to implementation, like this WONCA WHO declaration on the collaboration or on the integration of mental health into primary care started in 2008. But to be very honest, very little has actually occurred in practice. We're still hearing a lot of stories of all the obstacles, difficulties, because I think we need to have a more systemic approach to look at the system. So in this paper, we have identified the engagement, the enablement, that's really to do with the training, with the resources available, and also the empowerment of the primary care doctors to actually deliver the mental health to their patients. So the engagement, of course, we have actually, the MDD Mind project has engaged a lot of family doctors and some primary care team members. But that's actually the greater system. How about the policymakers, the politicians? How do you get actually government to think about, this is something that we should actually put it as a priority? Okay, so, and I think this is a very good timing because mental health after COVID has actually drawn the attention to many people, to most governments. Okay? And then like most governments are realizing that relying on the specialists or the psychologists, psychiatrists is not going to be able to actually meet the needs of all the mental health problems. And more governments are actually looking at primary care doctors, okay, where they can actually be accessible and where they can actually reach out to the people who are in need. So I hope that with that background, we'll go to the breakup discussions. We're going to have actually probably 2 in-person groups. And I'd like you to probably move, okay, we're going to use these 2 tables. So I'd like you to move to join the group with people whom you have not talked to too much, okay, in this past one day, and to actually sparkle some new exchange. And there's actually an online group which Zanka will help to facilitate with the participants of the YouTube Live. And so we'll have about 40 minutes for the discussion, and then after that, then we'll reconvene, and everybody, you can actually then share what you have discussed, some of the views. And I would like to encourage you to start with thinking more about the policy, because that's something that we have not actually discussed a lot in this past one day, and also the futures steps, and really focus on the strategies, actionable, that are actionable within months rather than years. Okay, so I think with that, so may I ask you to join your groups?
So,
and we'll come back at 40 past 2.
About half past.
40 minutes, I think, because it's still up to.
So,
what time do we?
So forgive us for just a sec. We want to rearrange you, but what we would like you to do is go and find someone you don't know very well, and then go take a place at the back table, which means if you've been sitting next to someone all day, find somebody different. So we're going to rearrange you in those back 2 tables. So stand up, find a new friend. New friend. And then we're actually, before you start discussing, we want Dr. Leonis, I think we're going to have you talk about sustainability. Now, or after or now?
Now, I think, no, it's, I'm leaving up to you, potentially after the exercise.
Okay.
After the exercise.
Okay, after the exercise. Okay.
I think that will be fruit.
Okay, perfect. All right. So go find someone. Go find, or if you find a friend that you already know, find some new friends. Back table there, back table there.
Okay, so we've now cut to this shot so they can see us here on the laptop. Right. So hello everybody who's joining us for the online breakout session. I'm going to leave you in the capable hands of Sanka, who's going to be moderating this session. And just bear with me while I just show him how to see your comments. So the comments will come up here. You can respond here as WONCA. And just bear in mind that there's also a 30-second delay.
All right. Okay. Yeah.
So if you're not getting immediate feedback, just bear that in mind. Okay. Right. Have fun.
Yeah, sure. Thanks very much.
So, I think what we'll do is 30 minutes, but we'll give you 10-minute increments so that you can talk The first question. Slide
Can you see it from here? Yeah, okay. Hi everyone. We hope that you are with us now. So we have 14. Oh yeah, please. Can it be seen from here or no? They won't see. They won't see.
Wait, I need thermals. Well,
Sorry about that. We got a little out of order. Oh, I have the question. Never mind. Roberto? I got it.
You got it.
Okay, this goes off.
You got the questions?
Chris, it will be. We can't see you, but we can see. We can only hear you through the text chat, as you told. Yes.
The first one. Sorry.
I think we need to move so. Yeah.
Oh, we lost everybody.
Yeah, good. Yeah.
This is all I need. Okay. I just need to take a picture and then we're good.
To take down your notes. How do we expand mental health care in training and resource distribution, cross-section collaboration?
Okay.
How do we do
Well, there's people leaving messages, but it says it's zero people watching, so I wouldn't trust that.
What are these?
All right. Okay.
Yeah, work away. I would say continue.
So
That's sorry. That's it's just strange.
Yeah, but I can see that Chris
Yeah.
is there.
Yeah. So,
Okay.
so work on it.
4. Okay.
Okay, so I'm going to ask the first question, which is.
Yes. So hi everyone. We hope that you are here. Chris, I can see Chris is there. Chris has been there. We can't see you, but I hope that you are there. So we are going to discuss about a few topics. One is it's about like training, resource distribution, collaboration, and also about policy framework relevant to mental health capacity building.
Okay, so I put that. In the
Yeah,
chat.
please.
Yes.
Yeah. So Mary is now typing the discussion topics on the chat. So we'll start with training initiatives. What do you think? What are your thoughts about this? Please comment on the chat because we can't see you. We can see you only through the chat. Is this this is the number or it's this?
This is the number.
Oh right, okay, lovely. Yeah.
They all went away.
Yeah, that's the number.
Right. We have 8 at the moment.
Okay. Sanka, what thoughts do you have about training initiatives?
So I think the best example for training initiative we have now is the MDD Minds Open project, right? The how we did the online project and how the resources are available now. So we had a structured, evidence-based, user-friendly program, which was open source, available for our family doctors. Not only family doctors, we also had it for the other rest of the primary care team. So I think that was one wonderful example for training that could be provided, because we are thinking of the basic knowledge that is important to go ahead for a primary care doctor, primary care professional to serve the patients and to increase the quality of care. So, yes. So, what do you think? Are there any other ways of like training primary care doctors, or do you think that this initiative was a fine example for that. We have to wait for a while, I think, because there's a 30 seconds delay, I think. Do we get anything? Not yet. And also you can think about including this into medical school curricula. Because we've just heard something from one of our colleagues from Mexico, where she was talking about whether we can include this into the medical school curricula or even to the postgraduate education.
Yeah, Dr. Dowrick, we need to be both realistic and optimistic.
Yes, exactly. And Chris is there. I'm thinking about how we need to be both optimistic and realistic. Okay, that's it. Yes.
Yeah.
Exactly, yes. Agreed, Chris.
Sanka, I have a question for you.
Yeah.
When you were in medical school, was mental health a significant part of your curriculum there when you were in medical school?
Yes, I mean, we had the psychiatry professorial appointments, and before that also, I think we had, 2 weeks appointment, 1 month appointment, and then the professorial appointment. But then the problem is that this was basically as a subject, as a psychiatry, but not the mental health for primary care. And I was really impressed by the question by Abdullah.
Yeah.
Because even though we talk about psychiatry in our curriculum, even for the family doctors, in our family medicine training, this is exactly not mental health for primary care. Because the mental health for primary care is different from psychiatry. And that's very important to discuss and train ourselves in the primary care settings rather than thinking of the hospital setup or else the secondary tertiary care setup. So I think one of the main problems in the medical school, the thing was it was not related much to primary care.
Yeah.
Rather than psychiatry, yes, of course, but not primary care.
Yeah.
Chris says that we are in a very difficult time globally and there are so many constraints on our time, but we can still think about what is possible. Yes. And we have another...
ensuring ongoing support and supervision for primary care.
Yes, ensuring ongoing support and supervision for primary care.
When you first started your practice, did you have a mentor or someone who could help you with primary care? Where did you learn how to integrate mental health into primary care?
I think when I started my practice as a family doctor, I think that was again, I didn't have any, additional knowledge except what I had from my family medicine or the general practice curriculum. But I would say a lot of insight was gained through the initiative we had in 2020, integrating mental health care into primary care leadership and advocacy program. Now Chris is here. Chris was one of the leaders there, and we had a sort of a one year program amidst COVID-19, where we did our own project in our practices, and that was very insightful. And I think after that, only I got involved in much in this the mental health programs with WONCA. So I think that is a fine example for getting young people involved in such things, and then now after that you become a trainer.
Yeah.
You were a trainee and you become a trainer, and you can sort of provide. You can expand your not only the care but also like opportunities, training, your knowledge, your attitudes. You can sort of spread that to the others as well. Support and supervision is so important. Our culture has been, family doctors should just get on with things, but that is such a bad way of doing things. Agreed. Yes.
It's you've now become a leader in family medicine. How have you supported your own or your younger physicians in Sri Lanka? I know you've been in the UK, but also as a leader within WONCA and family doctors.
I think, I mean, in different ways. Like it's not only related to mental health.
No, right.
Okay,
Yeah.
you're asking that the
Yeah,
open question.
broad-
Yeah.
broad question.
So I would because what I have realized is like my mentors and my senior colleagues, how they gave me the opportunity to become a leader, to become a sort of rounded physician. So I should do that the same and more to my young colleagues and my junior colleagues. So I have always tried to give them more opportunities to show their leadership skills. Now, as a young doctors lead of WONCA, what I did was like we created more opportunities for them to become different. A good example is Anna from Mexico. We created this young doctor liaison posts in the working parties, and Anna, who was a very enthusiastic colleague, became the young doctors liaison for working party on mental health. And she's here today as a leader, and you saw how she has inspired her colleagues in Mexico. So I think it's more or less creating more opportunities for young doctors and collaborations and allowing them to sort of learn from the world. I mean, it should be cross-cultural because always it's not only from your country. If you can get into especially a place like WONCA, you have colleagues from many countries where you can interact, exchange ideas, share your experience, and automatically you become a rounded person.
Yeah.
That's it. So I think it's more about giving opportunities for young leaders, so they will automatically find the paths.
Yeah, yeah. You've
Can you? Are you? Should I jot down something or should we?
No, we're good. I think we're good. Specialized training on communication skills with integration mental health.
Yes.
Into existing training programs. Yeah, communication skills. Do you want to offer anything about communication? How did you learn? Well, you're a wonderful communicator. What lessons could you give to someone?
Yeah, that's a good thing. I think, yeah, sometimes people are like, they are inborn communicators, but not only that, but they can also learn things by practicing.
Yeah.
And the other important thing is taking chances, opportunities whenever possible. I mean, sometimes people think, "Oh, I'm shy. I can't talk in front of an audience." But if you do it little by little, you can improve your skills, especially soft skills like presentation skills. And I think that's another good thing about technology these days, because now you will initially see people online, where I think it makes people to have less anxiety or less shy about the audience. So I think that's a good way of starting.
Yeah.
I mean, online audiences, talking in front of online audience, because no one is there in front of you. But then next step would be a physical audience.
Yes.
and certain things like presentation skills. Not only that, but I would also say how to prepare a presentation, how to attract people, how to keep the attention and concentration of people. Those things are very important. I think those things you can learn step by step.
Yeah.
I mean, mentors would be important, but also from role models. But I think I have learned a lot of things from role models, how they do. When you see a good presentation, you think, okay, I will do something like this, for an example.
Yeah.
providing specialized training for communication skills with the particular focus on integration of mental health education into existing training program.
Yeah, I think it's interesting. When do you teach communication skills? You know, is that part of a formal curriculum, or is that something that you learn once you get into practice? I know it's a lifelong skill,
Yeah.
but
I think even now in medical school, for example, in our medical school, there was a stream called personal and professional development stream.
Yeah.
Where also you get some chances to develop your communication skills, presentation skills, etc. But I think more than that, it's sort of a informal curriculum or the hidden curriculum. Because people, as you told, it's a lifelong learning. Every day you tend to improve your presentation skills and communication skills and interpersonal skills as well.
One of the things we included in the MD 101 or in the Train the Trainer
Trainer
curriculum was the requirement to do a presentation to
Yes.
someone. What was that? How did your scholars? Did they like doing that part of it?
I think,
or
yeah.
Were they new to that? So you could speak a little to how the curriculum
Yeah.
supported those communication skills.
So I think I feel that's a wonderful opportunity they got, because especially my scholars, the Sri Lankan scholars, they in each session we gave them a chance to talk, to do role plays, right? So one person would act as a patient and the other person as a doctor. And then we also shared the resources about how to do a presentation, and we gave some presentations already. So and what I found from the feedback was that they used them. Their presentations, they have done, some of them have done online presentations, and some of them have done physical presentations, but they have used our resources and they have done it well. I think they first got trained in the sessions, our own sessions, and then they were very confident to go out and deliver it to the rest of their colleagues.
Yeah.
I think we really achieved the target by the first training of TOT sessions, so the train of the trainers session, and going through that they go out and do the community sessions.
I have a friend who realized she was not a good public speaker.
Yeah.
And she decided to become a good public speaker by recording YouTube and Instagram as her to start. And then said once a month she was going to do a presentation to somebody.
Oh, right, okay.
So recognizing that sometimes when you're afraid of something, it's good to have somebody sort of push you into doing that kind of that kind of work.
So we can discuss about
policy.
Policy, yes, that's very important. Yes. We have, I think we have 8 people here. We would like to hear from you. Yes, strengthening policy. I think one thing that came into here by one of our colleagues was about policies. For an example, she told that antidepressants could not be prescribed by family doctors there. So I think now we have solid evidence that primary care doctors can manage major depressive disorders, and they can identify them early, they can treat them early, and our major focus was on non-drug interventions, but also sometimes we would need sort of drug interventions. But when there's a trained family doctor or even a trained doctor who is a fully fledged doctor is practicing in the community, and what is the how can we help them in like going to a policy where they have right to prescribe. So I think this is one of the main thing that we can evidence-based approach. We have to have an evidence-based approach because I think we have some evidence now, solid evidence. So you can talk about that as well.
Yeah.
Oh, you're there. Okay. Do people have things that they can reach? Yes. Can you see that what Chris has told?
Yeah. Yeah, I think.
You're talking about your spiral diagram.
Spiral diagram. Yeah, I think the question is, what do we need to show to policymakers? What do we help individual physicians put their own data together to show, and then use your member organizations within your own countries to help present and demonstrate.
I think that's a great idea, because I think one of the I would say strengths of this project was identifying right people for the project. Now all the stakeholders, I would say master faculty, I don't know who selected them, but I really don't know who selected. But I'm sure that the people who selected them knew that these people would be the best people to do this, because we can see how they have had their personal commitments to do this. I mean, it was mainly the personal commitment has achieved the success of the MDD Minds project. But how can we, as you told, how can we get the support of the member organizations also? Because if we are going for a policy change, definitely this member organizations, the professional organizations' contribution would be important. On the other hand, what is our audience? That is very important. The policymakers could be the politicians and also the high officials of the government.
Correct.
So when we are addressing politicians, I think a very important thing is we have to have stories. Politicians would like to hear stories, sensitive stories, which tug your heartstrings, heartstrings. And when it comes to professionals or the officials, they would also like stories, but they would also like to see solutions or data, evidence. So they would like to see the practical solutions. Politicians would love stories. So you have to identify the right audience, and I think accordingly you have to pitch.
Yeah.
That is, I think, very important.
We also talked yesterday about cost. When we can show a cost savings by returning a person to work, or
for example, if the MDDs or psychiatric disorders could be managed in primary care, how much cost would be saved? I mean, how much money or finance would be saved, rather than sending the patient to secondary or tertiary care and also delayed presentations. So that would be one point you can also think of.
Yeah, Chris's comment about scaling up, which is he's true. It's finding the right person.
And this is what Roberto has told about having representation of medical community in the policy decision bodies. On the other hand, I mean, having more primary care doctors or family doctors in policy making bodies. That's very important, I think, because sometimes we have a problem there, because our family doctors are more into clinical work rather than in policy making or administrative sectors. It has become a problem most of the time because there's no voice of family doctors represented in policy making bodies.
Yeah. But it is that combination of this stories, data, and cost, and then you need the messenger.
Yes.
Who is able to really craft that.
Yeah.
That we were talking to Joseph, and what made it work for him was he was in the right place. He now had data.
Yes.
And he had a proven program. So he was able to move that in. And how can WONCA support that, that effort for an individual doc?
Yeah.
Is important.
Definitely, yes.
And you're right, politicians are different than the government.
That's definitely right.
Because they're ultimately, the politicians come in, but very often I think it's government agencies that make the policies.
Yeah.
So
yes. So we have to impress politicians, and they will pass it on they will initiate the next process.
Yeah.
So that's the importance of politicians.
Yeah. No. Exactly.
Yeah.
Who are they, and where do they go? So yeah, I think it's valuable. I'd love to see every
And sure.
What if you were a politician? What data would you want?
I think, as I told, the politicians they would like to hear a story.
Yeah.
So we have stories here.
Yeah.
We have stories of our patients and our family doctors, how they have sort of changed the situation and how the quality of care has been increased and how the lives of patients have been changed by screening early, treating early, and in the primary care level. Then I would like to hear how this could help to save money. I mean, in cost cutting. I think I'm not a politician, but I think that would be one thing that would attract a politician to say that this has some impact. And Chris says this is where the advocacy project and MDD Minds come together perfectly. Yeah, this is talking about that integrating mental health care to primary care, and the advocacy project that the young doctors were involved.
Yeah.
Yes, we had 2 projects up to now. We had a alpha project, and then we did a beta project. So initially 16 people were trained, including myself, and then we had 8 people for the beta project. Now we have perfectly shaped project. I mean, we can go for a better next step. It's also like ready-made project. If there's a funding agency available, I think we can do a lot.
Yeah.
And should we also look at the KPIs, key performance indicators of any mental health initiative in the primary care? So
A question for you in Sri Lanka: do you have KPIs or quality indicators or
not for primary care, but we have in the ministry level we have this mental health section or the unit in the Ministry of Health. So they have KPI But I think up to now, the primary healthcare doctors have not been sort of strengthened, or their capacity has not built up by the ministry, because still I think because Sri Lanka has a bit of a issue with the primary care, not primary health care, primary care. Yet when you take primary health care, the public health, Sri Lanka is, I mean, brilliant, excellent. So for an example, the public health indicators are very, very high relative in relation to the other South Asian countries in the developed level.
Yeah.
I mean, the public health. But when it comes to primary care, the curative care, we have a problem. Because there's no family doctor system in Sri Lanka.
Okay.
So that's the next step, because now we just as we have achieved the public health or primary health care indicators, we have to go for the next step. It should be having a family doctor system and thinking of the primary curative care.
So for you then, advocacy really also is advocating for primary health care.
Primary care, I would say, yeah, where
you're advocating for primary care.
Where family doctor system could work well, where we can screen more. I mean, in relation to this, screen early, and treat most of the patients there. And whenever you need, you can refer the patients to the secondary and tertiary care. So I think in Sri Lanka, that is the challenge and opportunity both.
No, it's, I think that's very true. I don't think it's unique to Sri Lanka.
Yeah, there are some other. I mean, even some other South Asian, most of the South Asian countries have this problem. I mean, we have doctors practicing in the primary care without a postgraduate qualification, without family medicine qualification. And some of them were trained this time. I mean, we trained most of them this time in our cohort. There were, we had, I think, 300 something who were initially, I think, included in the program. But then even when you take the people who were in the TOT program, they are, like, some of them were not really qualified family doctors, but they are legally practicing in the. But I think the attitude change and the change that they had and how they got the change they received from this program is very important, because they are practicing at the moment in the primary care.
They're ultimately
community,
taking care of patients who have needs.
Yeah.
So it's.
So we have to be realistic, as Chris told, because we can't think of a perfect system with family doctors and only family doctors treating the patient at the moment. So we have to think about the people who are working at the moment. So it's important to build the capacity of them and strengthening them.
Yeah. It's a challenge.
It's a challenge, yes.
It's a big challenge. But necessary for policy.
Yes.
So our other question is future steps and sustainability of this initiative.
This initiative, the MDD Minds. Chris, from your side, do you have any ideas about sustainability? And we of course we had a discussion here. And I think one important thing is getting the involvement of the member organizations, because WONCA is an organization of member organizations. So even though member organizations got involved in this project, it was through the master faculty members. So I think there could be some sort of a more involvement through WONCA, giving some, more let's say, giving more recognition from WONCA's side to the member organization and making the project owned by them as well. I think that would be very much important when it comes to the sustainability of the project. Otherwise, that would be individual. It was like that. Mainly the individuals were looking at this, and you can see how individuals were master faculty members. So they did a lot. But when you talk about the sustainability, I think it should be owned by the organizations as well.
No, and agree completely. So what do those organizations need to know about this project?
I think now they can see what has happened with minimal involvement of them, but of course they got involved. I mean, they spread the word, and of course, but with the minimal involvement, they can see how many how many people have got trained, what the success that has been achieved, and what is how the quality of care has been changed in these practices, especially. So I think not only that, I think this is a good opportunity for the organization to see how the family doctors are leading the primary care team, because it's not only family doctors who got involved and who got trained. There were nurses, there were the healthcare workers, midwives in some countries, so, and even medical students, as I know. So all of them got involved in this. So, I mean, this is a very good opportunity to take the lead of the primary care team and go forward. And the resources are available. So, I mean, resources are freely available. So, I mean, they have a very good opportunity to take this forward.
Do you think it would help to have customized package of here's what happened in Sri Lanka to take to your back to your organization, or I'm thinking about sort of a report that here's the big project.
Yes.
But here in the
I think that's a very good idea, because what we saw was the big picture here.
Right.
But I think we also should have some sort of a breakdown to see how the Sri Lankan cohort behaved, and we can see the both strengths, and we can show the weaknesses as well, and where the challenges were and how the opportunities have opened up here. So I think that's a very good idea. I think each organization, especially who got involved, the countries where we can give them a report, even though you were not directly involved. This is what happened in your country. What your master faculty members, your members had done. I think that's a very good idea, Mary, I think. Yes.
We have often said, I'm happy for other people to take credit for something if it moves everything forward. So if they want credit,
definitely.
It means other ideas. Chris says you're making good points. We want country, what I'll call country brag books that talk about the really the big project.
Yeah.
And what is local to that country.
What for an example, what I observed in my group, there were less active members of the organization who got involved in this project.
Interesting.
So, which means there's a very good opportunity for the others. I mean, the active members would definitely be in.
Yeah.
Right? So, most of our scholars were not active members.
Interesting.
Would be sometimes associates of the college, not even members.
Interesting.
I think we have about 2 or 3 members out of the 13 people were members, and some of them were associates, not members.
Yeah.
And some of them neither associates nor members.
So how are you going? 5 more minutes? 5 more minutes. Yeah.
We're having a great conversation. 5 minutes, everyone. Okay. What about, I know you've been active with young family physicians, young members. Is there an opportunity to share this within that broader group to allow them to see the work that WONCA is doing?
Yeah, I think now here now this is a pilot project. This was a pilot project where we got only 9 countries involved. So what I saw on the social media was whenever we put this advertisement, okay, get enrolled into the program, everyone was asking why isn't this available in our country? So which means we have a lot more opportunity there. So we know that the pilot project is a success now. So I'm sure that definitely the young doctors would love to follow this and get themselves more sort of advanced knowledge on MDDs. But how we are going to do that, and what is the next step? What is the recognition we are going to give them? Those things will also be important.
We have lots to learn.
I think young doctors I think young doctors are much interested in this, especially so even some of the European countries. There were, I don't know whether you can remember, I asked this question when we were having some meetings where they were interested and they were asking, when will this project come to our country? So
it's been a big topic, and I think from my involvement, how do we train more of you? How do we make the resources so that it's easier to do?
Yeah.
But it can't happen without people like you. So we have to find a way to make that all. So let me see if we have any other. Do you want to ask them if they have any other comments?
Do you have any other comments, colleagues? In a few minutes we'll be stopping the group work, and if you have any other ideas about training, resource distribution, collaboration, and policy framework in relation to the mental health capacity building, you can just put it on the chat. And Chris has told that through real need across Europe too, especially in the one thing, very important thing is when it comes to the young doctors, I would say I never consider this the division between the LMICs and the HICs, low middle income countries and high income countries, because for young doctors all of them are just started their careers, and for young doctors there's no division like that. I think we have to be very, very open with them. I mean, we should not discriminate, telling high income or low and middle income.
Okay, so shall we come in?
Yes.
Yeah, so
Yes.
Sanka, I'll invite you to.
So how can I? Yes. Okay.
Just to report the course.
Should I go through this thing, or because I didn't?
We'll do it topic by topic.
All right. Okay.
That will be easier.
We'll make some.
I will go through the chat.
Oh, perfect. Okay.
Okay.
And we need to end at quarter past, right? Is that, yeah.
You have put the main points on the chat, right?
I put the main ones, but I think
So I
you
can probably.
remember, yeah, and I mean it's.
Yeah, sure.
You'll be fine.
3:30, so we've got a lot of time.
Okay.
Okay, in 1 minute's time, we'll be discussing the topics with the bigger group.
Thank you. I think you and I had a great conversation.
So I think I'm loud enough, so I'll give the mic to the table. Yeah, so we can actually give the mic to the table.
So probably I can use this and add.
loud enough, so I don't need a mic. And sound is also loud enough, so we give the mic to that table. So I'm sure.
But we will be.
Yeah, okay, great. So we got additional microphones. Yeah. So there you go.
Next.
So I have one, yeah. Okay, so yeah, we just wait for everybody to come back after. Yeah. Yeah, I think if you can actually stay with your discussion table, so that you because we've got a microphone on each of the tables, so then we can actually hear your points, both in person and also online. Okay, so excellent. So I hope you had enjoyed your discussion, and I had the opportunity to sit in some of the discussion. Was really fascinating to hear all the discussion. So we're going to probably bring back some of the messages that like you have actually identified from your discussion. And as I say, I always want to do things backwards. So can we start with the policy? So how can we actually make policies or encourage policies to help us build up or to strengthen the capacity of primary mental health care? So can I invite? They've got microphone, yeah. So, yes.
So start from me first. Okay, from the policy side, from our group, first we were talking about mapping the stakeholder and also dividing their impacts. We map the local stakeholders of faculty or institutions, universities, and then national level is associations, maybe association from family medicine, psychiatry, and also the governments such as the Ministry of Health, and then regional associations, and globally there are WHO, WONCA, WPA, and so on. And then we also talk about the successes from each countries. There are different successes from Kenya. What success that they have made in Kenya is that they did association with the Ministry of Health to train doctors in mental health guidelines and also protocols. And this is also provide then the training for give the data for to the government, the mental to the ministry, and from that data, the ministry then publishes guidelines and also educations, so policy that will make it mandatory for the training to happen, and then it will resonate to the workplace, and then the care of patients, and also the referral of patients to the correct specialty if they needed other kind of care such as psychiatric care. And then from Saudi Arabia, there are the key successes is that first, they also see the key leadership, that is the Ministry of Health. They reach out to the Ministry of Health, Um, through the training program, they give uh, 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 um, uh, ready-made, program, I think, and then the ministry allow them to do the training for doctors in the field, and from this training and implementation in the field, it's the data that was received was positive, and this influences the minister to further um, um, support the training, and then integrate it with the system, the health system itself. Yeah. And then afterwards, the interesting thing is that from this project in Saudi Arabia, it was implemented to other countries around it, like Egypt, Oman, Sudan, Morocco, Tunisia, and so on. Yeah, with the same approach. That
Okay.
is, reach out to the Ministry of Health,
Excellent.
which is the key person that will need to be reached out to be able to implement it.
Okay, excellent. So we identified as stakeholders, and then we will actually come up with success stories so that they can actually use it. And then, of course, usually governments are very competitive. Okay, so they see other people being successful in the region, they also want to match up to their success. So probably additional points from this group on the policy, the strategies in how we can actually facilitate the policy in strengthening the capacity of primary mental health care. Yes.
Okay. We were talking also like like collaboration with associations, governments, universities, and societies. We think that that is important to improve also prevention in mental health, to reduce the suicides and all things that are more difficult. And we also need to continue with research to make publication. So that can help us also to the government to make decisions to improve and put some more money to improve mental health in primary care. And we need more psychologists too, because maybe there's one or two and people need more. So like to have access to mental health like a right, not like a privilege.
Yeah, so some of the
like a right,
stakeholders
not a
will include the
privilege.
psychologists.
Yeah, because we
And-
have a lot of cost barriers, but because there are a lot of people that can't pay to have a therapist. So that's important for people, for everybody. Continue.
I think that's it. But an important point that we discussed is that before strengthening mental health in primary care, we should strengthen primary care. Yeah, and the collaboration should be around research to have the data to show politicians and everyone that we need policies, yeah, to resolve the problems that we see in the research. Yeah, it's important to have research about cost effectiveness, yeah, of this ideas, for example, and also we should discuss collaborations for the trainings, yeah, to solve the problems of primary care and also mental health in primary care. And what else? I think that's it. Joseph, do you want to say something?
Well, I think what we are saying that mainly they are the same, except that maybe that we need to be more country specific, because although these problems are common to globally, but the level to which they exist are different in the different countries. For instance, the primary care level in North America and Europe is completely different from what it is in Africa. So there may not be a single size that fits all. However, if we are specific, knowing the level of development of the primary healthcare in the first place, then we will now be able to know what to do to influence those people. But basically, we need to get across to the policymakers, as has been mentioned.
Yeah, so from the online discussion group, Sankar?
I think something we also discussed about the policymakers. We have to know what is the audience. So identifying the right audience is very important. So policymakers, who are the policymakers? It could be politicians and bureaucrats, both. But I think first it should be politicians. So usually we thought that politicians like the stories that tug heartstrings. So we have to have, we have a lot of stories here now, we know that. So we can use them for the politicians because they are the initiators of the policy making. And we should not forget our bureaucrats or the officials or the officers of the government. They would like to see the solutions for the challenges. So they would like to see data, evidence more. Politicians would like to hear the stories. So we have to address both. So we have to use our evidence and our whatever we gathered here, the stories and evidence accordingly, according to the right audience.
So we try to solve their problems. Okay, so any more thing that people would like to add on at the policy level? So probably Steve.
Yeah, I guess for me, policy work is about clarity and having very clear statements of intent. And then obviously there are the stakeholders, but actually getting the public behind you, very powerful. And when you do that, you need very clear logos, if you like, messages, mental health first, mental health matters, things that people can instantly understand and get behind. And then when you get the public behind you, if you get patient groups behind you, then you get power. And that's really where I think you want the collaboration at a policy level. If you get the community behind you, then the politicians have to listen. Thank you.
So can WONCA...
Just to add that, public and also media. We have media, public media, as well as now we have social media. Those could be used as very powerful tools when we want to influence the policymakers.
Probably WONCA can help think about the slogans and the statements and like where we actually how we wave the flag.
Definitely, and WONCA can help with the connections to patient groups. So, for example, we are about to sign a memorandum of understanding with the World Patient Alliance. So we are making official our collaboration, and I think patients should have a voice within this initiative, such as the MDD Minds, especially from the beginning, so that we are talking about co-creation of initiatives.
Excellent.
That's very important.
Right. Shani, you want to add something?
Well, I think what I heard in the groups were around the policy. Every region and country probably has a different way to tackle it, but there are 3 or 4 messages, I think, that are keys that we could come up with at WONCA around mental health. Yep. It's not mental illness, it's mental health. That would suffice for all of us. And then they could be taken back to the countries for personalization, depending on what they're paying, their government entity that pays or their health system. But if we can identify 3 or 4 really key, clear messages, I think that would be a great start.
Yeah, I think governments like to match up to each other. So like we have to tell them everybody's doing it except you. So, so Christos, words of wisdom?
I think that's more relevant, all of those issues to the sustainability. But I'd like in stressing a part of the media, as Sanka saying, that Stephen Harris that was saying, we needed in having with us the patient's voice, not only globally, but also locally. I think that's locally is very, very important. And I think that was an issue that a little bit we missed in MDD project. Thank you.
Okay, so yeah, remember the local, I think Joseph was also saying every country is a bit different. So shall we actually move quickly to the other topics? I'd like to talk about resource. Okay, so can we, So we start with this group first. So any key messages about how we can actually get the resource or distribute the resource or redistribute the resource? So you've got a magic wand. So what would you want?
We thought that the research is the key. Yeah.
So research is the key. So we need more research funding. Where do we get the funding? See, research is not born by itself. It's very expensive.
We discuss about medical societies, just like they said, for example, the family doctor societies, the psychiatrist societies, and also societies from other health professionals. Yeah, that would be a key. Also universities. Yeah, we could focus in master programs or doctoral programs.
Yep.
Yeah, to study these issues.
Mhm.
And also the data that we already have from MDD Minds,
Mhm.
yeah, that could help with the structure of the trainings and this sort of thing. Yeah.
Excellent.
Anything
So-
else?
Yes.
And we were talking also about like to improve education in medical health for medical students, because we think that we need a little more information and education about this topic, so we can see mental health problems better than now.
So how can we effect that change? How can we make medical schools put more mental health learning into the curriculum? I mean, they now actually keep adding genomics and whatnot. But so how? So what's the strategy we should take in order to get the medical schools to actually improve their curriculum, if I want to say that word?
Sometimes I have an impression that we discuss mental health as something very subjective, yeah, and then make this theme a little bit difficult, yeah, to assess. So if we have more practical trainings, more practical materials around the theme of mental health, that would help a lot, yeah. And one more time, I think MDD Minds, it's a way to get there. Yeah, it's simple, it's practical, it's up to date, is enthusiastic, yeah, and can play a role, yeah, in beginning this path. This
So we
new
make
path.
that available to the medical schools around the world. Yeah, so already made. Yeah. Yes.
Yes. Well, I just thought I could add this. You see, medical students learn what they will be asked or what they are most likely to be asked.
Assessment.
Assessment. So if we find a way of ensuring that at each level of clinical class, there will be some assessment relating to mental health, then not only will the teachers teach it, but even the students will be wanting to know it because it is going to be part of what will make them pass or not.
Put in a patient with depression in the examination. Yes. Okay, so we move to that group. Yes. So we're talking about resource. We actually have, and of course, yeah, the training we has also come to it. So resource.
About the training curriculum, yeah. So from our group, it actually also the resource also tackle the next two questions: the collaboration with the stakeholder and sustainability. For our group, said that the training curriculum first should be accredited by the stakeholders, from the local stakeholders, the associations, the family medicine or the psychiatry association. Yeah, so if it's accredited by the local associations, then it will prompt the institutions, the education institution, to also want to teach them. And then nationally, it from the associations and the university will go to the ministry and the government to also make this a part of the system. And then regionally, WONCA, globally WHO, and so on. But it could also go the other way around, such as the MDD Minds project, which is from WONCA, and then go to the local association, university, to integrate it. And then when the association and the university approve, then it will go to the ministry and disseminated nationally. And then the next one is about the sustainability and collaboration with the stakeholders, the other associations. Maybe we can do a joint training, and then also after a period of time or certified with this training, there will be a period of recertification for the trainers or participants to refresh their memories of practicing this mental health care to tackle depression and so on. Yeah. So there will be a recertifications. So it will be more sustainable, and people will keep on remembering the best course of action to do for each mental health problem.
Yeah, I think WONCA is doing something about accreditation of training programs and some recommendation on the core competencies for training in family medicine. Yes, Abdullah, yes.
Yeah. You know, for the guidelines on this, there's many guidelines, starting by ICD-10, DSM-5, MMH gap version 2, all this is there. But the problem, as I said with my group, the mental health, they don't have pathognomic symptom that the patient doctor will guide it. So when we create these pathognomic for target group, so the doctors, they have standardized interview. Any patient who came with organic disease or physical uncontrolled, this is one of our patient. Any patient who has frequent visits to healthcare, this group is our cases. Any patient with sleep disturbance, this is our patient. So these three, if we cover them, they mostly will cover the mental health problem. After that, then those patients who is not feeling in that, usually urgent thing or something is not or acute. So now I am sure that my doctors will not miss mental health problem. Then we move to screen him for hidden agenda, delusion by using the eyes, it's already there. Then we use him for the stress, he has psychological stress or not, by 3 questions also regarding the sleep, the performance and concentration, and the relationship. And this thing was compared in a big study and published in BMG with expert psychiatrists and BHQ-9 and GAD-7. Patient who has only early insomnia mostly have mild stress. Others, he has moderate to severe, mild, no need for medication. This one, he has medication with none. Then we move to the step 3. If this patient stay with us or refer to my colleague, it is clear for them who can be referred. Any patient with not depression, not anxiety, for example, psychotic, drug abuse, child postpartum, this is referred to psychiatry. Then we'll move to depression, to diagnosis step 4, using a BHQ-2 for depression, GAD-2 for anxiety, then move to management. The clear is structured for him. This is mild, just he take the 5 things for non-pharmacological with nutritional support. If he has moderate to severe, I do these 2 things plus the SSRI, which is safer even in the pregnancy. Next visit will be 2 weeks. We will teach him the narrative therapy, plus assessment and congratulation the response, usually 1 week, 2 weeks
So I think
response,
that
and 6 to 8 weeks remission, 9 weeks, months with the visit every 2 months, then decrease and stop the medication.
I think
The
that
patient
addressed
will
what
be
Andrea
clear,
was
happy, return to his life.
Yeah, I
Thank
think
you.
that addressed what Andrea was saying, that like to make mental health care like in a stepwise manner, and actually for easy for learners to actually follow how you do it step by step. Yeah, I think like, yeah, it shows like we've actually already moved to the training, but I want to come back to the resource. So any points from the online discussion on resource? So anybody, yes, Steve, treasurer.
Yeah, I mean, I guess resources for this kind of activity can be difficult. You know, a great part of the success of this project is the collaboration and being able to access funds we probably wouldn't have done otherwise. We need to think how we can get involved in other consortium or other collaborations, bringing the strengths that we bring, and we have undoubted, global reach, expertise, many things. Probably sophisticated grant applications, less so, or being aware of funders. Certainly, if you're aware of anyone that might, or any organization that might be a good funder, let us know. And that's certainly something that we want to build more relationships with. But having collaborations like this is been a great success for us, and we should build on that model. Yeah, thank you.
I think just to add a little bit on this, here there is a great model. Again, I'm repeating myself from this morning of what is possible, because you started, and I oftentimes when we're speaking about change, I love the Kotter's 8-step approach. So when you want to lead change to something, you start with the urgency. You saw the data. There is a need here to address. Okay, and then you form your winning coalition. Here is the winning coalition: the people who first got the urgency to act, and they acted. They developed a program, right? And it's so inspiring, because at the end of this 8-step approach, you have, if you want to make change stick, you have to make it institutional. And I heard Anna this morning, and they want so you said that you are including it in the curricula. Excellent. And that's what you would like to do in Indonesia as well. So there you have the resources of leading change from the small urgency, from the big urgency, from the small team, up to the institutional change.
Yep. Yeah. So one strategy is to start with what's under your control, like be it like your postgrad students, your medical school curriculum, your government programs. So start, and when you've got some results, then like they will take notice, and including research funding. Like we were able to actually move governments to actually set aside commission grants to enhance primary care. So the importance of primary care on mental health, because we show them the needs, and also a few success stories, like pilot programs, and then they say, okay, we really want to have more evidence, so they'll give you the money to do the research. Yeah. So can we actually move to, okay, we have actually talked a little bit about the collaboration. We have talked a lot about the primary care team collaboration. So anything more to add in the like biggest cross-sector collaboration? We have heard a little bit about the psychologists. So probably start with this group. So anything you want to add about cross-sector collaboration?
Probably what we wanted to add on the sustainability, it crosses over to the collaboration, is having, we looked at 3 programs. There was the 101, there was the TOT, and there was the practice. And the practice is something we are forgetting so much in our discussion.
Mhm.
We would want to see probably an accreditation mark for the practices that do their QI, and this can be monetized. And this is something that WONCA can take up to have an accreditation mark and have an accreditation team.
So you have to, yeah.
That does that for the QI projects. Let's make this something that every family physician looks to have in their practice as something they are accredited for, that they are doing a MDD mind quality improvement project in their workplaces, and it's reassessed maybe every 2 years or 3 years as would be agreed by the committee. Then looking at collaboration, the associations are strong, especially the regional. How do they get to help you to ensure that those accreditations are done? And not everyone is traveling everywhere. They can do the accreditations for their region. Thank you.
Excellent idea. Yeah, yeah. I mean, hospitals are doing these accreditations, so I think practices, like if they actually undergo these improvement projects, yes, yes. Is it working? Okay, take mine.
Sorry, thank you. There is one area regarding collaboration that I think we need to emphasize again, particularly for regions of the low and middle income countries. And that's the collaborating with the psychiatrists, the mental health specialists, especially the psychiatrists. I think there will be, it will be most helpful if WONCA could take an initiative in this area, because many of the resistance that we have in getting through as primary care clinicians with interest in mental health is that there is a lot of resistance, although it may be passive, by these specialists, thinking that family physicians are trying to take over their specialty in those areas. And this is not true, but there's no way they know because they are the specialists there. It's particularly important in these countries because the psychiatrists are themselves moving out in droves, going to other places, but they still have that listening ear of government that says, no, we are still the psychiatrists, but they are moving out. So now, more than ever, is when the people in primary care needs to really be able to do something about mental health. So there's a need for WONCA to, through advocacy, get through to psychiatrists, maybe through the WPA, psychiatrists in other countries or the associations, that they should support this program. Thank you.
Yeah, so the psychiatry, I think WONCA has a collaboration with the World Association of Psychiatrists. Yeah.
And I think there's a good opportunity here because if you see at the program, the MDD Minds program, we have more sort of elaborated at the screening, non-drug interventions, and also referrals.
Yeah.
So I think it's like it is very clear that it's not harmful to the psychiatrist at all. So it's more or less about primary care practice mainly. So I think we have a good opportunity with our evidence and our examples that we can probably reach out to them.
Yeah, so Yasmin, you're going to say something. Okay. So any more that to add on collaboration from this table? So of course, I mean, it's really not only the psychiatrists. I think many other specialties, they see a lot of mental health problems. And we're talking about the comorbidities. Yeah, Christos. Okay, great. Yeah. Okay, so and
Cindy, probably
yes,
the
online
opportunities we had about the when we see the training of trainers program, there were a lot of nurses, other health professionals, midwives who are in the primary care team had been trained. So I think this is a good opportunity for collaborations. I mean, one way it's like the family doctors are leading, but also the team,
the nurses,
primary care team is there, and they are being also trained by this program. So that's a good one for the collaborations and also the sustainability.
Sustainability, yeah, that's right. Yeah, so we increase our capacity. Yeah. So and then we of course talk about the patient groups as well. Yeah, and I think that group also discuss about how we actually get the patients to demand better mental health care that's accessible, affordable, and not only available. Yeah. So any other points I can actually see? Yeah.
Two other comments from the online chat. One was about making sure that the member organizations in each country has not just the report, but understands the impact that that report had in their country, so that they become advocates for this work. Sanka and I were chatting. I said, I personally am never sorry when someone else takes over credit for work that I've done, as long as it moves the ball forward. So if the Sri Lankan Association all of a sudden says this was the greatest thing I've ever seen and takes credit for it, that's fine. So one is, and that's I think an easy step to take.
And actually, we were thinking now, when you take the master faculty, whoever selected them, they have selected the best people who are inspired to take this forward. And we saw when we talked to our colleagues, they are the people who actually personally committed to get this successful project. So on the other hand, for sustainability, I don't think that individual commitment would adequate per se. So in that case, I think member organizations could play a big role by seeing the success of the project. Without much involvement of them, still it has become a very successful project. So they can make this, there's some sort of an ownership to this, and they can go forward. So that would be another way of making it a sustainable project.
Yes, sure.
Thank you very much. One last one for sustainability. And I thank Harris for the reintroduction to a team that we are working with on the ground called Medtronics. And what we have been doing, we reintroduced, they had an app for NCDs that the community health promoters are able to link their household to the facility, those who have NCDs, and form support groups. Though we added a component of mental health, but you see, we added a component, but we never trained. So I'm seeing an opportunity for an MDD to partner with Medtronics and be able to add that component of training and move the project further in terms of ensuring we also do some support groups. Probably the next round, can we form support groups? Because we are talking of patient groups, maybe forming of support groups and seeing how support groups work, and also looking for funding for support groups, because there is a lot of money that's going towards ensuring support groups are working. Thank you.
Excellent. So so one final point, because I'm actually looking at the time, so very, very rich discussion. So any final comments? So yeah, if not, then I think we'll probably draw this session to a close, and then we'll move on to the next one on sustainability. Okay, thank you all very much for your contribution. Excellent points.
I think that's enjoying very much the discussion and the dialogues, and I suppose that was very fruitful and constructive, and given a lot of suggestions. And we decided just leaving this presentation at the end because we wanted just leaving you in expressing quite as a volunteer basis many very constructive discussion. I tried a little bit to summarize. I think that many key achievements have been discussed. And I think I utilized ChatGPT in a little bit making more structure this presentation. And of course, always declaring a conflict of interest. I think that we needed a strategic approach at the moment. Just to discuss ensuring continuous funding, expand the audience and networking, update the content and training material, leverage marketing and awareness strategies, enhance accessibility and inclusivity, and working with implementation data, measuring the impact of the project implementation and disseminating of the results. That I think that, and planning now a little bit discussing all of these 6 steps or 6 directions. First, to ensure continuing funding, I think that we needed a subscription model. Many of us having some ideas what that means, subscription model. Of course, already we have discussed, and this is the important role of a steering committee of a CEO of a WONCA and of course esteemed honorary treasurer to identify grants and sponsorship, apply for mental health grants and seek a partnership with the funding organization. There are many opportunities at the moment and having a partnership for funders and also health grants. I think that's just very important, not only in the European setting. So we're having still a lot of European Commission projects are coming across, not the last 6 months, but the previous year, the European Commission announced many call for funding focusing on mental health. Unfortunately, we did not succeeded in submitting any of them. Corporate sponsorship, that some of them you are talking about a service organization to promote employee wellness resilience. Service organization is quite very important and potentially looking not only the region but also locally. I'm thinking that many service organizations are trying a little bit to train the employees how to having mental health promotion. I think that a lot of issues how to ensure continuous funding. The second is expand on the audience and engagement and networking. Already some of your suggestions coming focusing not only with the governing organizations, but also with the professional organization. We trying in the working party in having a communication with World Psychiatry Association. I think that is very, very important. And it's key message also not only for mental health regarding the psychiatrists, but also from other medical disciplines, and especially the disciplines they treat in non-communicable diseases. I think that collaboration with the nurses, I think that is very, very important. You started thinking already, you mentioned it but also with the psychologist. And still, even in our working party, we have psychologists, not nurses, but I think that are challenging, and potentially we started communication, of course, under the support of WONCA Global. The accreditation is developing an accreditation already has been discussed, and it needed to discuss what it means by saying CPD credits, and it's important also in thinking WONCA regional organizations and and member organization, I think that is another chance. And of course, gamification means we needed a little bit talking about many of other tricks, other pathways in working in enhancing our networking and engaging more organizations and audience. I think that also I'm remembering we have discussed many times before that asking colleges related to affiliated to the WONCA just a little bit utilizing MDD, not only just to translate in the language, but also potentially just expanding. I think that is an effort tested before, but we need it. This is, to my view, is the more a substantial step because without funding support, it's difficult to continue. Talking about addition, engagements and networking is not only thinking other networks that are doing a relevant job as with us. And this is United for Global Mental Health. We started working with this organization of young people who are just trying also enhancing the leadership according, and this is one of the latest publication. I'm thinking that we needed having such a mapping exercise in understanding what other networks or global initiative focusing around of mental health. This is also a job of a WONCA Working Party, and we needed the support of all of you. Now we come into step 3 about to update. I suppose that first task is reporting our achievements, our results, but also started thinking to what extent new dimensions, in new directions, additional context. I think that is very important. Already mentioned just having, I think that's Steve already mentioning that having more experts on that. That means expert collaborative efforts, not only with other health professionals, but also experts in training modules, I think, and already, of course, discussed about the World Psychiatric Association. And also important and also consider additional technologies now and potentially using AI-driven personalization and many other stimulators. I think that potentially could explore when starts thinking how to update content and training material. And of course, when talking about this is also after funding, to my view, is the second in priority. Already have discussed in coming across additional disciplines and our MDD project at the moment that's focusing on how to equip more health professionals. But I think that MDD now needs a little bit expanding the horizon and just needed and seen the integration of primary care, mental health with public health. I think that is an issue that's a little bit not only looking at the individuals, patients with depression, but also looking on specific groups and population-based. I think that is another unique that potentially mental health promotion and global mental health, as in advocacy we discussed. I think that is a case. Already the vulnerable groups potentially will be another direction. And in another European project we have in the University of Crete and the University of Athens, we started thinking how to address mental health issues in trans people. Transgender issues is very important for Europe at the moment, and the majority of them have been enormously affected by discrimination, and discrimination is a key issue. And there are many supporting evidence that social discrimination and etc. discrimination is connected also with a non-communicable disease, especially cardiovascular disease. I think that's already we discussed by yesterday, a little bit already discussed in MDD, but I think social prescribing as a concept already baptized in UK, I think that could be expanding. And already discussed about giving a more focus on compassionate care, and already by yesterday I was presented the latest on the right leaflet in a book of WHO, means at the moment is under the umbrella of WHO. And already some of you that is talking and address narrative medicine. We have, of course, many patient stories at the moment, but I'm thinking that, and of course, suffering, together with Chris, who started discussing, giving a more focus on suffering, not only suffering from mental health, not only suffering from a non-communicable disease, but simply because they thinking that living in an uncertain world is an issue of, and also giving more focus on meaning of life, especially when just addressing the younger people. I think that the fourth is making more focus on marketing and awareness strategies. Social media campaigns already have been discussed. Marketing, I'm not familiar with the content of marketing, but I think that's blogs, webinars, infographics already have been in a fantastic way addressed by WONCA Secretariat and WONCA CEO. Referral programs, I think that also already have discussed to attract new participants and contribute to awareness strategy. Enhance accessibility and inclusivity, that we needed a little bit all of this MDD project. Potentially we thinking to what extent is just addressing a mobile app integration. The multi-language support is a very important issue, and potentially through colleges and other already discussed. And the last is working with implementation data. I think that now is our next chance. Tomorrow in the steering committee we will be discussing about the publication strategy. Already we have received many comments from you, but most important is thinking how to disseminate the results, how to report, and how to publish and enhance the project visibility already. And I'm thinking now, it depended, we have not now with us Dr. Richard Horton, but it is very, very important a little bit trying in having an impact or a connection with the Lancet Commission. That's saying the Lancet Commission now discussing global mental health. I think that is important in having an involvement. Previously, we have some individuals' participation, but we needed in consider WONCA side. I think that from all, and I'm putting this not only expressing a thanks for your attention, but this was an opinion for here, for Brussels, a few years ago. And potentially since one of the key achievements of MDD was a little bit enhancing or making more confident the people in terms of self-care, potentially we just is an additional proposal in how to a little bit more instructions, more coming across to making family physicians more resilient and more self-confidence. I think that is with some thoughts, and many thanks for giving me this chance in summarizing many of your ideas. Thank you. I think
Okay, it's my turn. So, hello everybody, and for anyone who doesn't who I haven't said hello to, my name is Diarmuid Hayes, and I'm the Communications Officer here at the WONCA Secretariat, which means that I work full-time with WONCA, trying to make the case for family medicine on a global scale, trying to facilitate communications within the many groups and working parties, and yeah, trying to distill what you guys are talking about today and make that simpler and clearer to the people outside in the room. So I have a hard job. But today I'm here to talk about World Family Doctor Day, which, as you will all be familiar with, is a global campaign created by WONCA since 2010. It's been celebrated on the 19th of May every year, and it's a global celebration of the role that family doctors play in healthcare systems around the world. And who's the tech guy? So, as you might have noticed, last year we dedicated World Family Doctor Day to the area of planetary health. And we talked about the role that primary care can play in planetary health, being that family doctors are constantly rated as one of the most trusted people in their communities, for them to become advocates for the environment, to make that link between planetary health and the health of their patients, and also making the case that primary health care is a sustainable form of providing healthcare, universal healthcare for people around the world. And we had a really good engagement from our members and family doctors around the world who really bought into this. More and more, I think member organizations are embracing the idea of World Family Doctor Day. And for us, and as WONCA, as a community, it's an opportunity for us to be very visible. It's one of the days in the calendar year where we're most visible. So these were some of our campaign documents from last year. We had a very successful video where we got people to contribute on the same message, family doctors all around the world reading off the same script, which was very effective. And lots of people changing their profile pictures, and lots of webinars. People also organize in-person live events as well. There are some of them from Bangladesh, Taiwan, Slovakia, I think, I forget. So this year, our theme is going to be on the role that primary care can play in mental health. So as we were discussing earlier what the next steps of this project might be, this could be one of them. This is one of them. And the theme that we came up with, workshopping with Chris and Christos, was building mental resilience in a changing world. And this acknowledges, I think, that mental health and that people are increasingly having issues or presenting with mental health issues, and the role that family doctors can play in helping people prepare that through the core values of family medicine: continuity of care, the person-centered approach, lifestyle medicine, and preventing problems before they become a crisis or more acute. So this year, 19th of May, is a Monday, and we'll be celebrating World Family Doctor Day. And our objectives, as we said, were to celebrate the contribution of family doctors, also to demonstrate the role that primary care can play in mental health, and also to showcase WONCA and our leadership in global health initiatives, like the MDD Minds project, and also its role as a peer support network. I'm sure everybody here has been to a WONCA conference and sees the value of having the community and the webinars, the young doctors movements, and people getting together and offering that peer support. So with Chris and Christos, we've developed a couple of key messages, as Steve was outlining there, to try and just distill things down and make things simpler and easy for people to understand, so you can kind of drill them home. And we're talking about how primary care, again, is uniquely positioned to promote family wellness through its the emphasis on relationships, and sorry, I got through it in there. Through the early interventions, holistic understanding of patient lives, etc. Then also we want to make the connection between doctor well-being and patient care and how they reinforce each other. And this is, I think, a nice idea. I like what Steve was saying about taking the oxygen mask and treating yourself first. But also we want to enforce the idea that looking after patients is a cycle, that in turn gives you fulfillment and meaning in your life that sustains you then to go forward, and that they're intertwined and they reinforce each other. A thriving doctor means a thriving community, and this is again linked to that. We want to talk about how WONCA fosters this global support network, strengthening the family medicine community, and how WONCA contributes to that, valuing family doctors. That's what World Family Doctor Day is really all about. And fourth, then, when I asked Professor Dowrick what would be the most important thing for him to tell every doctor, a family doctor around the world in the world of mental health, he said the most important thing is to acknowledge suffering and offer hope. So he'll be, I guess, speaking more about that as the campaign goes on. And finally, this was another idea that came up, that mental health is, we need to foster this idea away from an ideal of mental health as this unrealistic utopian goal, and talk more about ideas of resilience, adaptability, balance, as Professor Leonis has spoken about. So those were our key messages. I've done that one already. And our primary audience is our own community of family doctors. Our secondary audience, we want to speak beyond to the policymakers, to potential stakeholders, and the general public. And our planned activities involve some media outreach, some social media. We have a toolkit and a website ready to go. We have, again, we're going to be doing a video, and then there's a webinar series, which we've this year kind of taken a top-down approach, with direction from the Working Party on Mental Health to avoid some overlap. We want to maybe try a global physical event because people are meeting in person and doing something, and if we could kind of get harness that energy and that enthusiasm, that would be nice. And then finally, there was a I'll talk about the global physical events. So this is one idea that I had, that people might go out and do running or something like this, and then we can contribute their runs or their photographs and stuff, and we could all celebrate that in one location. And then the global musical collaboration project is an idea that's been developing quite recently, but during the lockdown, the Mental Health Party recorded a music project, and we're thinking about replicating that by getting some buy-in from, yes? Yeah, this is a video, but I only have 10 minutes, so I didn't have time to play it. But I'll send a link around afterwards. It's great. Yeah. So we're going to try and do that again, and if you're interested in contributing, get in touch. You can sing. And our webinar series then, and as we were saying there about branching out, last week we arranged that the World Patient Alliance would co-host one of these webinars with us. The Young Doctors Movement is going to take another one, but we're going to try and reach out to other organizations to collaborate on these webinars so we can get their members and audiences to come into the fold and celebrate World Family Doctor Day with us. And that's it. For the moment, that's all I have. But if there's any questions or any suggestions or ideas, I'm open to them, and you can send them to me later.
Viviana's video. Yes. So we are just minutes before closing. We are very privileged to have also a video message from the president-elect Professor Viviana Martinez Bianchi, who sent us this recording.
Distinguished colleagues, valued partners, and dear friends. Today, we have come together in celebration, honoring the incredible journey of the MDD Minds initiative. This is more than the completion of a project. It is a testament to WONCA's shared commitment to transforming mental health in primary care. Through dedication, collaboration, and innovation, you have laid the groundwork for lasting change, ensuring that mental health is recognized as an essential part of primary care. Mental health is a fundamental human right, yet major depressive disorder remains one of the leading causes of disability worldwide. In low-resource settings, up to 90% of those affected go undiagnosed or untreated. Behind these numbers are real people, families, and communities that are suffering in silence. At WONCA, we have long championed the idea that mental health must be part of primary care. Family doctors and community health workers are often the first and sometimes the only point of contact for individuals struggling with depression. But to serve them well, we must have the right knowledge, the right tools, and the confidence. This is why MDD Minds has been truly transformative. Over 2,500 clinicians in 9 countries engaged in training. Nearly 600 completed the program, strengthening their ability to diagnose and treat depression. 126 family doctors trained others, reaching 1,697 additional healthcare professionals. And in Brazil, Japan, and Nigeria, depression screening is now being integrated into routine diabetes care, a model for chronic disease management that can be followed worldwide. Beyond numbers, the real impact lies in the stories of change. I think of the family doctor in Sri Lanka, now confident in counseling rural patients with depression. I think of the team in Brazil, where community health workers are screening patients at home. And I think of that colleague in Nigeria who shared that learning about self-care was just as valuable as learning about patient care. These stories remind us that mental health care is about more than medicine. It is about people, connection, and compassion. But our work does not stop here. We must expand mental health education, ensuring more clinicians, especially in underserved regions, benefit from these resources. We must strengthen policies that integrate depression screening into standard primary care. And we must care for those who care, supporting the well-being of our family doctors and primary care teams. MDD Minds has proven that when we equip primary care providers with knowledge and confidence, we can change lives. But this is just the beginning. WONCA remains committed to keeping mental health at the forefront of primary care, and I invite each of you to be part of this next chapter. To our partners, trainers, and every clinician who took part in this journey, thank you. You're not just improving mental health care, you're transforming the future of family medicine. Together, we will continue this mission. Every patient deserves to be seen and supported. Mental health must be a core part of every primary care consultation, because when we care for mental health, we care for the whole person. Thank you. Muchas gracias. Obrigada.
Big thanks to Viviana Martinez Bianchi for this very beautiful message about compassion and about the importance of family doctors and how we need to care for the whole person and for all people of the world. So this concludes our day. I would like first of all to thank each one of you from the master faculty who has worked almost 3 years to make this project a reality and who has traveled here to participate in this celebration. I would like to thank the Working Party on Mental Health, Professor Leonis, but also the father of the MDD Minds, the father of the MDD Minds project, Professor Chris Dorick, who unfortunately is not here with us. A big thanks to all of the participants of the project, almost 3,000 of them who have enrolled to the project, and many more that will come afterwards. A big thanks to our funder, Pfizer, for being generous and providing an unrestricted unconditional fund for us. Thank you to the team here at the WONCA Secretariat, and of course, our partners for implementation, design and implementation at Mosaica Solutions. We thank you so much. And finally, to the global community of WONCA, which continues to believe that mental health is a huge part in primary care. And we continue working towards the integration of mental health in primary care. Thank you to all of you for coming.